Now we'll go to the musculoskeletal system of Pance Prep Pearls. This will be an audio of Pance Prep Pearls, and it will also have corresponding images for each condition as we go through them to get a better full understanding, especially as orthopedics is very visual. So first we'll start with Compartment Syndrome. This is muscle and nerve ischemia due to decreased tissue perfusion when a closed muscle compartment pressure is greater than the ability for it to be perfused. Etiologies is most commonly trauma, especially after a fracture of the long bone, which is 75%, and especially involving the lower extremities from crush injuries or constriction, like tight casts, splints, and circumferential burns. Clinical manifestations are pain out of proportion to the injury, which is most specific. And remember, this is your 6 Ps: pain out of proportion, paresthesias, poikilothermia, pallor, pulselessness, and pain and paresthesia are the earliest symptoms. Physical examination, pain with passive stretching is the most sensitive earliest exam finding. Pain with passive stretching of the affected muscles. You'll also feel a tense compartment or a firm wood-like feeling. And there, once again, will also be pulselessness, pallor, decreased sensation, and paresthesias, but these are more late findings. And also capillary refill is usually preserved in these patients. For compartment syndrome, diagnosis is by an increased intracompartmental pressure of over 30 millimeters of mercury, or a delta pressure of under 20 to 30 millimeters of mercury indicates the need for a fasciotomy. So the change in pressure equals the diastolic pressure minus the compartmental pressure. You also see for diagnosis an increased CK and myoglobin due to the breakdown of muscle. Management, you want to do prompt decompression. This is by emergency fasciotomy to decompress the compartmental pressure. While awaiting decompression, place the limb at the level of the heart without elevation prior to decompression. Supportive management, remove all constrictive dressings, IV fluids, and oxygen. So, while you're waiting for the fasciotomy, place the limb at the level of the heart, not elevated. Next will be chronic osteomyelitis. This is a chronic infection of the bone which occurs for months to years. Etiologies, staph aureus and staph epidermidis, and staph epidermidis especially with prosthetic joint infections. You can also have gram-negative infections like Pseudomonas, especially with IV drug users, and also E. coli, and it can also be polymicrobial. Sources can be direct inoculation, which is infection close to the bone, status post-trauma, surgery, or insertion of a prosthetic joint, once again more common with staph epidermidis. Or it could be contiguous spread with vascular insufficiency, such as in diabetics, as well as peripheral vascular disease. You can again have acute hematogenous spread, which is not a common cause in adults. Vertebral osteomyelitis is the most common cause of hematogenous osteomyelitis in adults. Hematogenous spread is more common in children, however. So vertebral osteomyelitis is the most common area for hematogenous spread. Next, clinical manifestations of chronic osteomyelitis. You'll see a sinus tract drainage and nonspecific symptoms. The involved limb may be edematous, warm, swollen, tender, with decreased range of motion due to the pain. For diagnosis, you get radiographs, which you'll see soft tissue swelling, periosteal reaction, osteopenia, and bone destruction. You also see a sequestrum, which is segments of necrotic bone that have become separated from normal bone, and an involucrum, which is new periosteal bone formation that surrounds necrotic bone, the sequestrum. So sequestrum versus involucrum. MRI versus CT scan, more sensitive than radiographs, and bone biopsy is essential to identify the pathogens and obtain sensitivities. For management, surgical debridement and cultures are the initial treatment of choice for chronic osteomyelitis. Unlike acute osteomyelitis, empiric antibiotics are not recommended, so you want to do that culture from the biopsy in chronic. Antibiotic treatment is based on culture and sensitivity. Next, acute osteomyelitis. This is once again an infection of the bone, most commonly seen in children. The femur and the tibia are the most common bones affected in children. The vertebrae, most common bone affected in adults. Risk factors: sickle cell disease, diabetes mellitus, immunocompromised, and pre-existing joint disease. Sources: acute hematogenous spread is the most common route in children. Direct inoculation, infection close to the bone, post-trauma, such as open fractures or puncture wounds, or surgical, insertion of a prosthetic joint would be a direct inoculation. And there's also contiguous spread with vascular insufficiency, again, with diabetes and peripheral vascular disease. So 3 different main sources for this. And the notable organisms in acute osteomyelitis. Staph aureus is the most common overall. Group A, strep pyogenes is also possible, but Staph aureus most common overall. Staph epidermidis, coagulase negative, increased incidence after recent prosthetic joint placement, also in neonates and children with indwelling catheters like chronic hemodialysis. Salmonella is pathognomonic for sickle cell disease, so know that. Group B strep, increased incidence in neonates. And Pseudomonas, you could lead to calcaneal osteomyelitis associated with puncture wounds through tennis shoes, more common with Pseudomonas, and IV drug users. Clinical manifestations: non-specific constitutional symptoms like fever, chills, malaise. Also signs of bone inflammation like bone pain, warmth, swelling, and tenderness. Also limitation of function, restricted use of the extremity, decreased range of motion, limp, and refusal to bear weight on it. For labs, increased ESR and CRP. CRP is more useful. White blood cells increased. Blood cultures positive in 50%. So you want to get cultures even of the blood. Radiographs, usually the initial test ordered. Evidence of bone infection may not be evident for up to 2 weeks after symptoms onset. For early, soft tissue swelling and periosteal reaction, but later on you'll see lucent areas of cortical destruction. And for this acute osteomyelitis, MRI is the most sensitive test in early disease. CT scan often used for surgical planning. Radionuclide, bone or gallium scan is sensitive in early disease, and bone aspiration is gold standard, definitive. So the antibiotic treatment for acute osteomyelitis. You want to give antibiotics for 4 to 6 weeks, at least 2 weeks via IV, and they also may need debridement. So this is a longer course, 4 to 6 weeks for osteomyelitis. Has to get all the way into the bone. So it's classified by age, organism, and empiric therapy. So age. If they're from neonate to 3 months old, you're concerned for group B strep and gram-negative bacteria. So you want to start empiric therapy with 3rd generation cephalosporin like cefotaxime or ceftazidime, plus an anti-staph agent like vanc or nafcillin or oxacillin. So 3rd gen cephalosporin plus vanc or nafcillin. That's for 0 to 3. 3 months to adults, you're concerned of MSSA and MRSA. So you want to give nafcillin, oxacillin, cefazolin if MSSA, or if MRSA, vancomycin, clinda, or linezolid. If they have sickle cell, this is pathognomonic for a salmonella infection, and you want to do 3rd gen cephalosporin or fluoroquinolone, Cipro or Levo. And if they have a puncture wound, you're more concerned for Pseudomonas, and you want to give cefepime, ceftazidime, or Cipro. Next, osteoarthritis. This is a chronic disease due to loss of articular cartilage and joint destruction, joint degeneration, minimal and absent inflammation, most common in the weight-bearing joints, knees, hips, spine, and wrist. If the hand is affected, the DIP's involvement is greater than the PIP or MCP, as opposed to RA. Risk factors: modifiable or obesity, trauma, and heavy labor. Non-modifiable: increasing age, female gender, and family history. Female gender because the increased Q angle of the hip to the knee. Clinical manifestations: joint pain, usage-related, stiffness and restriction of movement. The pain is usually worse in the late afternoon and evening. Clinical manifestations also evening joint stiffness worsens throughout the day and with weather changes. If morning stiffness is present, it is of short duration, under 60 minutes, as in comparison to RA. Physical exam, the joint will be a hard, bony joint, decreased range of motion, and crepitus. No inflammatory signs. You might have Heberden's nodes, which is DIP enlargement, or Bouchard's nodes, which is PIP enlargement. For radiographs, you'll see classically asymmetric joint narrowing, marginal osteophytes, subchondral bone sclerosis, and bone cysts. Labs, lack of inflammatory markers, normal ESR, CRP, ANA, and rheumatoid factor will all be negative. For management, you want to do lifestyle modifications first, such as weight management, moderate exercise, and use of assistive devices. And then first line, acetaminophen is the preferred initial analgesic if mild to moderate pain. And then NSAID is next, topical or oral. Although NSAIDs are more effective, NSAIDs are associated with increased adverse effects in the elderly, like GI bleeding and renal injury. NSAIDs may be used if no relief with acetaminophen, or no risks or contraindications exist. Once again, like renal disease, heart failure, peptic ulcers, GI bleeds. Topical NSAIDs have better safety profile and can be used if a few joints are affected. Duloxetine in some patients with multiple joint involvement in whom NSAIDs are contraindicated. Remember, duloxetine is that SNRI that helps with the neuropathic pain. Topical capsaicin may cause a local burning or irritation and has an exothermic effect. Intra-articular corticosteroids provide temporary relief, usually about 4 weeks, and then joint replacement if function is compromised. So once again, to review the difference between OA and RA on radiograph, OA, we'll see the osteophytes and the joint narrowing. This will be asymmetric joint narrowing. There'll be marginal osteophytes, subchondral bone sclerosis, and bone cysts. As for RA, we see symmetric joint narrowing, osteopenia, bone and joint erosions, and also ulnar deviation in severe cases. Next, for rheumatoid arthritis, this is a chronic systemic autoimmune inflammatory disease with symmetric polyarthritis, bone erosion, and cartilage destruction, and joint structure loss. Remember, it forms a pannus, a hyperplastic synovial tissue, leading to destruction, T-cell mediated. Risk factors for RA are women, 30 to 50, smoking, and remember this is an HLA, DRB 1 and 4. Remember, DRB also seen in diabetics type 1. Clinical manifestations, symmetric constitutional symptoms, fever, fatigue, weight loss, anorexia, joint pain and stiffness, morning stiffness over 1 hour after initiating movement, but improves later on in the day, as opposed to OA. You'll also see decreased range of motion. Most commonly affects the smaller joints, the wrist, MCP, PIP, and MTP, and also the ankle. Characteristically spares the DIPs. Felty syndrome is RA plus splenomegaly plus neutropenia, and Kaplan syndrome is RA plus pneumoconiosis plus pulmonary nodules. Physical examination, symmetric inflamed joints, warm, erythematous, soft, boggy, ulnar deviation of the hand, swan neck and boutonniere deformities, rheumatoid nodules over bony prominences as well. Diagnosis, rheumatoid factor, the best initial test, but anti-cyclic citrulline peptide antibodies, anti-CCP, is the most specific. Increased ESR and CRP. So, rheumatoid factor is the best initial test, anti-CCP is the most specific. Radiographs, symmetric joint narrowing, osteopenia, bone and joint erosions. Severe is associated with joint subluxation. Plain radiographs are often normal in early disease. Cervical spine involvement can be seen, leading to subluxation, especially the C1 and C2 subluxation. So don't forget cervical spine involvement in RA. Management. Prompt initiation of DMARD, disease-modifying anti-rheumatic drugs, to slow the disease progression, especially methotrexate, leflunomide, and NSAIDs, or for immediate symptom control. Methotrexate and leflunomide are preferred in patients with high disease activity and advanced disease. Glucocorticoids are second line for symptom relief. It does not slow the disease progression, as methotrexate does. So again, distinguishing between RA and OA. Here we're going to go over the feature and then RA and OA. Primary joints affected in RA: wrists, metacarpal phalangeal, proximal interphalangeal. DIPs are spared. For OA, we have DIPs and the thumb. The thumb is the carpal metacarpal joint. Heberden's nodes are absent in RA, and OA they're frequently present. Joint characteristics: soft, boggy, tender in RA, hard and bony in OA. Stiffness: worse after resting, morning stiffness, and morning stiffness over 60 minutes is RA. And remember, OA, worse after effort, evening stiffness. If stiffness in the morning is present, usually under 60 minutes. X-ray findings in RA: osteopenia, symmetric joint narrowing, and radiographic findings in OA: osteophytes and asymmetric joint narrowing, as well as subchondral sclerosis. Lab findings for RA: positive rheumatic factor, anti-CCP antibody, ESR and CRP, and OA will have negative findings of these. Next, we'll go into some of the different disease-modifying anti-rheumatic drugs, the DMARDs. First will be methotrexate. This is a non-biologic DMARD. Mechanism is a folic antagonist. That's why it's also used in abortions. Indications: initial DMARD in most patients with RA. Can be used in combination with other biologic DMARDs. Methotrexate and leflunomide, good for severe or high disease activity. Adverse effects: liver, lung, bone marrow, hepatitis, interstitial, pneumonitis, amiodarone 2, bone marrow suppression. Leflunomide is an alternative to methotrexate with similar efficacy. It's a T-cell inhibitor. Hydroxychloroquine. Indications: can be used in mild disease or if diagnosis is uncertain. Can also be used in combination with methotrexate. Hydroxychloroquine is also safe in pregnancy, but also know the retinal toxicity as you need with hydroxychloroquine, eye exams required on therapy. Also ototoxicity. Sulfasalazine, usually reserved for patients unable to take methotrexate or leflunomide. Adverse effects: hemolysis, especially in G6PD deficiency, rash, hepatitis, bone marrow suppression. And remember, DNP, dapsone, nitrofurantoin, primaquine, also sulfasalazine for G6PD deficiency. Next, the biologic DMARDs. All patients on biologic DMARD should have a PPD to rule out tuberculosis before initial therapy. TNF, tumor necrosis factor inhibitors. Etanercept, infliximab, adalimumab. Adverse effects: reactivation of tuberculosis and other chronic infections like hepatitis B and C. They should be avoided in patients with MS. So you have anakinra, is an IL-1 receptor antagonist, used when other DMARDs are not effective. Increased activity when used with methotrexate. We have rituximab, which is a CD20, anti-CD20 B-cell depleting monoclonal antibody. Used when methotrexate they're not responding to methotrexate. And again, adverse effects: reactivation of chronic infections like TB, HBV, HCV. Abatacept, which is a CD28 blocker, inhibits T cells. Again, reactivation of those same chronic diseases. Next, anti-inflammatory medications for symptom control. You have NSAIDs, of course, mechanism, analgesic and anti-inflammatory. First line for symptom control, but does not affect disease course. So DMARD must also be initiated to slow down the progression of the disease itself. Of course, adverse effects: GI, gastritis, peptic ulcer disease, renal insufficiency, Cardiovascular, increased risk of bleeding. Corticosteroids. Mechanism suppresses inflammation, low dose orally, IV, or interarticular routes. Adverse effects: hyperglycemia, cataracts, weight gain, fluid retention, immunosuppression, hypertension, osteopenia, prevents calcium binding with vitamin D. Next, septic arthritis. This is an infection of the joint cavity. This is a medical emergency as it can rapidly destroy the joint. The knee is most common joint involved in older children and adults, over 50%. The hip joint is the most common joint in younger children. Sternoclavicular joint septic arthritis can be seen in IV drug users, importantly. Like Staph aureus and Pseudomonas can be seen there. Risk factors: extremes of age, chronic medical condition, immunosuppression, medications, HIV, IV drug use, diabetes, also prosthetic joints and surgery, chronic arthropathies like rheumatoid, gout, and osteoarthritis. So for septic arthritis, some of the notable organisms might be a staphylococcal species. Staph aureus is the most common organism in all age groups, over 50%, including IV drug users, especially MRSA. So Staph aureus is the most common in even IV drug users, but also note Pseudomonas is possible in IV drug users. Staph epidermidis, increased incidence with recent prosthetic placement. Strep species, second most common cause. Group A strep, Group B strep in neonates and infants under 3 months, and strep pneumoniae. Neisseria gonorrhea, sexually active young adults, especially associated with tenosynovitis. So that's your RTA for gonorrhea. Your rash, tenosynovitis, and arthralgias. RTA. Pseudomonas, increased incidence in immunocompromised, such as IV drug use, older adults, neonates. Mycobacteria and fungi are less common. Clinical manifestations: joint involvement, swollen, warm, painful, and tender joint with decreased range of motion. Tenderness with micromotion. Constitutional symptoms: fever, chills, diaphoresis, myalgias, and malaise. Diagnosis: arthrocentesis is the best and most accurate test. White blood cells greater than or equal to 50,000, and they're also primarily neutrophils. White blood cells over 1,100 are considered positive in a prosthetic joint, however. Aspirate also examined for crystals, gram stain, and culture. Increased ESR and CRP, non-specific markers for inflammation. Although white blood cells, ESR, CRP are usually monitored to assess response to treatment, CRP is more useful. Blood cultures are positive in 50%. Radiographs may show soft tissue swelling, MRI and CT. For management, prompt IV antibiotics, joint drainage, and debridement as needed. Joint drainage: arthrotomy, open surgical drainage, needle aspiration, or arthroscopic drainage. So, based on the gram stain, what antibiotics will we be giving? If there's no organism seen, it's empiric: ceftriaxone and vancomycin, plus or minus an anti-Pseudomonas if expected. Again, ceftriaxone for the gram-negatives and vanc for gram-positive. If you find gram-positive cocci, you can do vanc or nafcillin if MSSA is suspected. Gram-negative or gonococcal, you want to use ceftriaxone, cefotaxime, and ceftazidime or fluoroquinolones. And if you have gram-negative rods specifically, ceftazidime plus gentamicin. Next will be hip and pelvis injuries. Developmental dysplasia of the hip. This is an abnormality in the shape and or stability of the shape of the femoral head in the acetabulum. Examination of the hip is performed during newborn screening soon after birth and at every well visit until about 9 months of age and or the child is walking independently. Risk factors: especially a breech presentation at birth, also firstborn children, females, and a positive family history. Physical examination for developmental dysplasia is assessing for hip instability, asymmetry, or limited abduction. The Barlow maneuver. Barlow maneuver, gentle adduction without downward pressure to feel for dislocatability, resulting in a click, clunk, or a jerk. The Ortolani maneuver, abduction and elevation to feel for reducibility, resulting in a click, clunk, or jerk. Other findings may include asymmetry, such as observing the skin fold differences, femur length or gait, and restricted hip abduction. In infants over 3 months, the dislocation may become relatively fixed, and the Galeazzi test can be used instead. So to go further in depth with the Ortolani and Barlow maneuver, for the Barlow maneuver, how I remember it is bar and then low. So bar as if you're lifting up on a bar, aka adducting, and then low as if you're pressing low, therefore posteriorly dislocating the hip. And you keep your finger on the femoral head from the outside, and you're pressing down with the base of your hand. So the examiner adducts the fully flexed hip while applying posterior force to the femur, resulting in dislocation of the hip. Next, the Ortolani maneuver. The Ortolani maneuver reduces the hip. As we just said, the Barlow maneuver dislocates the hip. So for the Ortolani maneuver and reducing the hip, the examiner grasps the medial aspect of the knee and abducts or goes out, so Ortolani out, abducts the hips while applying anterior force to the femur, resulting in a reduction of the hip joint. May feel a clunk. So with that finger on the femoral head, you're pressing inwards, so that's going to reduce the hip inside of the acetabulum again. Diagnosis, clinical, with confirmation by imaging. Ultrasound, importantly, is often used in children under 4 months of age, as cartilage is not formed fully to bone yet. AP radiographs in older children, however. Management, under 6 months of age, you want to use a Pavlik harness, and from 6 months to 2 years, closed reduction in the OR may need an arthrogram. Monitoring with routine hip radiographs until the child is skeletally mature may be needed. Hip dislocation assessment using the Barlow and Ortolani maneuvers. In infants over 3 months, the dislocation may become relatively fixed, and the Galeazzi test can be used instead. Next, pelvic fractures. Mechanism, high impact injuries, such as an MVA. Also possible to have low impact injuries. Clinical manifestations, symptoms can vary from pain with ambulation to inability to ambulate. Acetabular fractures are most commonly occurring with an associated lower extremity, abdominal, or neurologic injury. They may also have perennial ecchymosis, also known as Fox sign. Diagnosis, imaging, radiographs. CT scan may be indicated if radiographs are negative or to get more details. Labs, CBC to monitor any blood loss, blood type, and screen. And remember, perennial ecchymosis, the Fox sign, can also be seen with hemorrhagic pancreatitis, in which you also see the Cullen sign and the Gray-Turner sign. Anywho, management of pelvic fractures depends on severity. Weight bearing as tolerated for most pubic rami fractures, also pelvic binder. Open reduction internal fixation for more severe fractures. For bleeding, a pelvic binder and IV fluid resuscitation is often used initially with vessel embolization if refractory. Complications include DVT, especially, sciatic nerve pain, and vascular injury. Next, hip dislocations. Associated conditions, fractures of the hip, or pelvis, or knee injuries. Mechanism, trauma again, most common cause, most commonly an MVA. This is an orthopedic emergency. Posterior hip is the most common dislocations at 90%. Axial loading on an adducted femur. Anterior is most common for shoulder dislocations. Anterior, there also can be an anterior, about 10%, axial loading on an abducted and externally rotated femur. Associated conditions, fractures of the hip and pelvis or knee injuries. Physical exam. For posterior hip dislocation, which is 90%, the hip pain with a leg shortened, internally rotated, and adducted with hip and knee slightly flexed. So, physical exam, the posterior dislocation is hip pain with shortened leg, internally rotated, and adducted. Anterior may be externally rotated and abducted. Radiographs. For posterior, the femoral head appears smaller than the contralateral side and the femur appears adducted. Anterior, the femoral head appears larger and the femur appears abducted. Management, conservative. Closed reduction under conscious sedation. Not performed if there is an associated ipsilateral femoral neck fracture. Open reduction. Complications? Avascular necrosis, up to 13%. Reduced with early closed reduction under 6 hours. Sciatic nerve injury, DVT, and bleeding. In anterior hip dislocations, the femoral nerve is the most commonly injured nerve. So remember, complications, avascular necrosis, sciatic nerve injury. Next, hip fractures. Mechanism, minor or indirect trauma in the elderly, high impact injuries in younger patients. Most common, osteoporotic women. Common in elderly patients with decreased bone mass. 3 main types of hip fractures. It can be the femoral neck, intertrochanteric, or subtrochanteric. So starting with femoral neck fractures, this is proximal cephalad to the trochanters. Fractures of the femoral head and neck are associated with a higher incidence of avascular necrosis. Very important. Intertrochanteric, between the greater and lesser trochanters, and subtrochanteric, below the trochanters. Intertrochanteric and subtrochanteric are extracapsular. Femoral head and neck fractures are intracapsular. Physical examination, hip, thigh, or groin pain with the affected leg shortened, abducted, and externally rotated, similar to an anterior hip dislocation. Management, open reduction internal fixation, or arthroplasty are surgical options. Hip prosthesis may be used for femoral neck fractures, pinning for some intertrochanteric fractures. May observe if high surgical risk, minimal pain, or non-ambulatory prior to fracture. So once again, posterior hip dislocation is adducted and internally rotated, but here in a hip fracture, shortened leg, abducted and externally rotated. So again, to compare, posterior hip dislocation, hip pain with shortened leg, internally rotated and adducted, with hip and knee slightly flexed. Hip fracture, hip, thigh, or groin pain with the affected leg shortened, abducted, and externally rotated. Next, leg calf Perth's disease, idiopathic avascular necrosis of the femoral head in children due to ischemia of the capital femoral epiphysis, usually unilateral. Risk factors, children ages 4 to 10, importantly, smoking exposure, 4 times more common in males, obesity, coagulation abnormalities such as factor V Leiden, decreased risk factors, low incidence in African Americans. Clinical manifestations, pain-less limping for weeks, worsened with continued activity, especially at the end of the day. May have a mild intermittent hip, thigh, or knee or groin pain, and may have an antalgic or Trendelenburg gait. Restricted range of motion, loss of abduction and internal rotation, may have atrophy of the thigh muscles. Patients may lag in bone age and height. Radiographs, early, increased density of the femoral epiphysis, widening of the cartilage space. Advanced, deformity, positive crescent sign, which are microfractures with collapse of the bone. Importantly, positive crescent sign. Management, observation, activity restriction, non-weight bearing initially, with orthopedic follow-up is initial treatment in most cases. Usually self-limiting with revascularization within 2 years. May advocate for protective weight bearing during the early stages until re-ossification is complete. Physical therapy or a brace and cast. NSAIDs for pain management. Surgical, pelvic osteotomy may be indicated in some children over 8 or more advanced disease. So once again, to summarize, leg calf Perth's disease, idiopathic avascular necrosis of the femoral head in children due to ischemia of the femoral epiphysis. Next, slipped capital femoral epiphysis. Displacement of the femoral head epiphysis from the femoral neck through the growth plate. Risk factors, children 8 to 16, obese, African Americans, males during adolescent growth spurt due to weakness of the growth plate and hormonal changes at puberty. If seen in children before puberty, suspect hormonal or systemic disorders, hypothyroidism, hypopituitarism, very important. Clinical manifestations, ipsilateral, dull, achy hip, groin, thigh, or knee pain with a painful limp worsening with activity. Physical exam, an externally rotated leg on the affected side, limited internal rotation in abduction, and flexed on range of motion of the hip, an altered gait. Diagnosis, radiographs, posterior displacement of the femoral epiphysis, similar to an ice cream slipping off of a cone. Best seen on the frog leg, lateral pelvis, or lateral hip view. Management, non-weight bearing with crutches, followed by internal fixation with pinning. So, slip capital femoral epiphysis, also known as SCFE. Femoral head epiphysis slips posterior and inferior at the growth plate, seen here. Popliteal or Baker's cyst. Popliteal synovial fluid effusion is displaced with subsequent cyst formation. The mechanism is degenerative or inflammatory joint disease. Clinical manifestations, mostly asymptomatic. If they are symptomatic, it'll be posterior knee pain and stiffness. You'll see a mass behind the knee and possible knee effusion. Ruptured cysts may present with pseudo-thrombophlebitis syndrome, mimicking a DVT with tenderness, warmth, and erythema to the calf. So have that on the differential. Diagnosis, Doppler often performed to rule out DVT, also helpful to identify the cyst. And management is conservative. Initially, you want to start with ice, assisted weight bearing, and NSAIDs. You can also do an intra-articular corticosteroid injection or surgical excision for refractory or severe cases. Next, we'll move into the knee and knee injuries. So first, the MCL and LCL, medial and lateral collateral ligaments. The MCL resists valgus force or lateral trauma. The MCL injury is more common than the LCL. LCL resist varus force, so medial trauma pushing outwards. Clinical manifestations, localized knee pain, swelling, ecchymosis, and stiffness. The LCL will have pain and laxity with varus stress, and the MCL pain and laxity with valgus stress. Management, if there's a grade 1, which is a sprain, or a grade 2, which is a incomplete tear, you want to be conservative with pain control, physical therapy to restore range of motion and strength. Also RICE, rest, ice, compression, elevation, NSAIDs, and knee immobilizers. If there's a grade 3, which is a complete tear, may require surgical repair. Next, ACL injuries or anterior cruciate ligament injuries. This is the most common knee ligamental injury, may be associated with meniscal tears as well. 70% are sports related, more common in female athletes. Mechanism, non-contact pivoting injury, deceleration, changing in direction, hyperextension, and internal rotation. Manifestations are associated with a pop or swelling followed by hemarthrosis, and they also may develop knee buckling and inability to bear weight. Physical exam, the Lachman test, is the most sensitive. This is when the knee is placed at 15 degrees in supine position. Forward anterior translational movement over 2 millimeters when the tibia is pulled forward is positive for ACL injury. Pivot shift test, while maintaining internal rotation, valgus force is applied to the knee while it is slowly flexed. Positive if the tibia's position on the femur is reduced or if there is anterior subluxation with extension. The anterior draw test can also be done, which is similar to Lachman's, but it's at 90 degrees. This is also least reliable though, as spasms may stabilize the knee. For diagnosis, radiographs are usually first to rule out a fracture, and also know a Sagond fracture is an avulsion of the lateral tibial condyle with varus stress of the knee. If present, the ligamental injury are also most likely to be present. Pathognomonic for ACL tear, so that's Sagond fracture. MRI is the best test to assess ACL tears. For management, this is controversial often and depends on the activity level of the patient to determine versus therapy versus surgical. Conservative, rest, ice, NSAIDs, compression, and physical therapy. If they do decide surgical reconstruction, this will be due to significant knee instability with desired activities, young active patients under 40, and those with a high demand job or athletes. This may be performed with an allograft. You should also know the unhappy O'Donoghue triad, injury to the ACL, MCL, and medial meniscus. So that's MMA. Medial meniscus, MCL, and ACL. Posterior cruciate ligament now. The mechanism most commonly associated with dashboard injuries as anterior force to the proximal tibia with the knee flexed, a direct blow injury, or a fall to the flexed knee, usually associated with other ligamentous injuries as well, other PLC injuries as well, the posterior lateral corner injuries. Clinical manifestations, posterior knee pain, anterior bruising, especially with the anterior medial aspect of the proximal tibia, also a large effusion. On physical exam, posterior draw test can be done. Looks for posterior translation of the movement of the tibia. Diagnosis by MRI. In management, conservative, do your ROSH therapy, NSAIDs, knee immobilization, and this may be done if isolated PCL injury. Surgical may be indicated if an acute injury or if associated with multiple injuries. Meniscal tears. The mechanism is degenerative or acute. Could be axial loading and rotation, such as squatting, twisting, compression, or trauma with femur rotation on the tibia. And no, for meniscal, medial is 3 times more common than lateral. And the medial meniscus is actually much larger than the lateral meniscus. Clinical manifestations, popping and giving way during ambulation or climbing or descending stairs, and effusion after activities. Locking, inability to fully extend the knee, especially if there's a flap tear, or depending on the type of meniscal tear that there is. Physical exam, positive McMurray sign, a pop or click when the knee is flexed and then externally rotated and extended. The Apley test, joint line tenderness, joint effusion, and swelling. This is the Apley grind test. MRI for diagnosis and management is conservative with rest, ice, NSAIDs, orthopedic follow-up, physical therapy. Can also do surgical for arthroscopic repair or partial meniscectomy. Severe symptoms, persistent symptoms despite conservative management is when you do surgical. Next, for patellar fracture. The mechanism is a direct blow, most common. Fall on a flexed knee or forceful quadriceps contraction, most common in young patients. Clinical manifestations, pain, swelling, or deformity. Limited knee extension with pain. Diagnosis by radiographs, you'll see a sunrise and cross-table lateral view allow for better visualization of the patella. For management, if it's non-displaced, just use a knee immobilizer and a leg cast, but if it is displaced, use surgery. So again, that's a sunrise view for a patellar fracture. And the most common is transverse. Osgood-Schlatter disease. Apophysitis of the tibial tuberosity, inflammation of the patellar tendon at the insertion of the tibial tubercle due to overuse, repetitive stress microtrauma, or small avulsions from repetitive knee extension and quadriceps contraction. The apophysitis is a muscle tendon bone attachment that is subject to injury from repetitive stress or an acute avulsion injury. Risk factors, most common in males, 10 to 15 years old, and during growth spurts, as well as in athletes. Clinical manifestations, activity-related anterior knee pain and swelling, such as running, jumping, kneeling, and relieved by rest. Prominence, swelling, and tenderness to the anterior tibial tubercle. Diagnosis, imaging is not usually required in classic presentations, but for radiographs you may see elevation, heterotropic ossification, and or bone fragmentation of the tibial tuberosity. For management, conservative is the mainstay. Rest, ice, elevation, compression. NSAIDs, quadriceps strengthening, knee immobilization. Most symptoms resolve within 1 to 2 months. 12 to 24 months, so 1 to 2 years. Surgery is only done in refractory cases. If done, usually performed after growth plate is closed. Next, patellar and quadriceps tendon ruptures. The mechanism of these ruptures are forceful quadriceps contraction, falling on a flexed knee, walking up or down stairs. The quads more common than the patellar. The quads rupture usually over 40 years old. Patellar rupture is usually under 40 years old. Risk factors are males over 40 and history of systemic disease like diabetes, gout, obesity, renal disease. Clinical manifestations: sharp proximal knee pain with ambulation, inability to extend the knee and perform a straight leg raise. Quadriceps tendon rupture, a palpable defect above the knee, and patellar tendon rupture, palpable defect below the knee. Diagnosis: quadriceps tendon rupture, patella baja, a low-riding patella, and quadriceps and patella tendon rupture is patella alta, a high-riding patella. Management: knee immobilizer, non or partial weight bearing, and rice. Surgical repair usually performed within 7 to 10 days. So again, patellar tendon rupture, you have the patella alta, as the patellar tendon can no longer keep the patella down, and with any quad contraction it will move up. Or the quadriceps tendon rupture, which is the patella baja, so the patellar is lower than normal. Patellar dislocation is next. The mechanism will be a valgus stress after a twisting injury or a direct blow. Lateral is most common in females. So you can imagine if you're having a lateral force, the patella can slip to that lateral side. Diagnosis by apprehension sign: patient exhibits anxiety, forceful contractions of the quadriceps when the examiner pushes laterally. Only performed if patellar is already reduced. Also, radiographs can diagnose. Management is a closed reduction. Push anterior-medially on the patella while gently extending the leg. Post-reduction film should be obtained. Knee immobilization and full extension, and quadriceps strengthening. Also abductor strengthening as well. Next, knee or tibiofemoral dislocations. This is a severe life-threatening emergency. The anterior is most common, but posterior has a high incidence of popliteal artery injury, importantly. It can also be lateral, rotational, and medial. For mechanism, high-velocity trauma, often associated with a multiple trauma. Gross deformity will be obvious. 50% spontaneously reduced before arriving in the ER, so believe patients that say this. Management: immediate orthopedic consult for prompt reduction via longitudinal traction with vascular status checks. If intact, place in a splint. Most cases will need emergent surgical intervention. Complications: vascular, popliteal artery injury in 1/3 of patients. You must perform arteriography or arterial duplex if pulses are diminished or absent. Normal pulses do not rule out arterial injury. If pulses are normal, an ABI can be performed. If the ABI is over 0.9, serial exams can be performed. If under 0.9, that's an indication for arteriography or arterial duplex to assess further if there is popliteal artery injury. Neurological: peroneal or tibial nerve injuries. Peroneal nerve is the most common, also known as foot drop. Femoral condyle fractures is next. Mechanism is by axial loading, falling from a height, or a direct blow to the femur itself. Clinical manifestations: pain, swelling, inability to bear weight. Complications: peroneal nerve injuries, a foot drop or decreased sensation to the posterior first web space of the foot. Also popliteal artery injury. Immediate orthopedic consult, open reduction internal fixation, and also to note it usually heals poorly. Next, tibial plateau fractures. The mechanism: axial loading, rotation, direct trauma, most commonly seen in children in MVAs. Location: lateral plateau is the most common, bicondylar, and then medial. Clinical manifestations: pain, swelling, hemarthrosis. If displaced, check for peroneal nerve injury, such as foot drop. Diagnosis is by radiographs, may be hard to see though. CT scan for further definition and pre-surgical planning. Management, conservative, non-weight bearing initially with hinged knee brace, and partial weight bearing and passive range of motion, plus an orthopedic follow-up may be used if non-displaced. Surgical if displaced or severe. Complications often associated with soft tissue injuries, meniscal or ligamental tears. Lateral meniscal tears are most common. Also, compartment syndrome needs to be ruled out. Post-degenerative arthritis in over 50% and loss of joint congruity are also complications. Next, patellofemoral syndrome, also called chondromalacia. Idiopathic softening or fissuring of the patella articular cartilage from overuse. Risk factors, most commonly seen in runners or cyclists and women, climbing and descending stairs as well. Clinical manifestations, anterior knee pain behind or around the patella, worsening with knee hyperflexion, prolonged sitting, jumping, or climbing. Physical exam, compression of the patella during knee extension will produce symptoms or a positive apprehension test, anticipating pain. So similar to the patellar dislocation. Management, NSAIDs, rest, rehab, initial management of choice, strengthening of the VMO, vastus medialis obliquus, of the quadriceps, and weight loss. You could also use an elastic knee sleeve for patellar stabilization. Next, IT band syndrome, iliotibial band. Inflammation of the iliotibial band bursa due to lack of flexibility of the ITB bursa. Pathophysiology, excessive friction between the IT band and the femoral condyle laterally. Risk factors, runners and cyclists. Clinical manifestations, lateral knee pain, especially where the IT band courses over the lateral femoral epicondyle. The pain is classically sharp or burning and worse with changes in terrain, such as climbing stairs or running downhill, usually relieved by rest. So you want to palpate the greater trochanter to rule out bursitis there as well. Physical examination, positive tenderness over the lateral condyle, pain reproduced with single leg squat. You could do a positive Noble compression test, positive if pain over the distal IT band, especially at 30 degrees of knee flexion with pressure applied to the ITB. Positive Ober test, pain or resistance to adduction of the leg parallel to the table in a neutral position, also tests the TFL, tensor fasciae lata. So Ober, one leg over, or Ober, the other, in adduction. Whereas Noble takes a Noble patient to take the pain to palpation. Management, conservative, is the initial treatment. NSAIDs, ice, avoid overuse, PT. Also corticosteroid injections and surgical intervention in refractory cases. Next, moving to ankle and foot injuries. So ankle sprains. Lateral. 85% of ankle sprains involve the lateral ligament complex. The ATFL, anterior talofibular ligament, is most common. The calcaneofibular ligament, the CFL, and the posterior talofibular ligaments are also common. But the ATFL is the main stabilizer during inversion of the foot. For medial, that would be the deltoid ligament sprains are usually due to eversion injuries. So it's important to get the mechanism of injury in these patients. Clinical manifestations, patient may have felt a pop followed by swelling, pain, inability to bear weight, as well as ecchymosis. Diagnosis, anterior draw test can be performed to assess ATFL integrity. The Taylor tilt test assesses CFL stability. And also it's important to know the Ottawa ankle rules. So when should you get a radiograph for an ankle injury? So you'll get an ankle film if there's pain along the lateral or medial malleolus and inability to walk over 4 steps at a time of injury and in the ER. And you'll get a foot film if you have pain over the navicular, midfoot pain, or pain at the 5th metatarsal base, so where a Jones fracture might be. Management, conservative. Rest, ice, compression, elevation, NSAIDs, crutches for the first 2-3 weeks, ACE wrap to support. Achilles tendon rupture. Mechanism: mechanical overload from the eccentric contraction of the gastrosoleus complex. Risk factors: 75% occur as sports-related injury, episodic athletes, and weekend warriors. Increased risk with fluoroquinolone use and corticosteroid injections, common in 30 to 50-year-olds. Clinical manifestations: sudden heel pain after a push-off movement, or a pop, a sudden sharp calf pain, inability to bear weight. A positive Thompson's test, importantly, would be positive if weak or absent plantar flexion when the gastroc is squeezed and the patient is prone while doing this. Diagnosis: radiographs, usually initial test of choice to rule out ankle fracture or other causes of pain, but an MRI is the best test for this Achilles tendon rupture. Management: non-operative, splint initially in mild plantar flexion. Resting equinus. You want this to put the tails, so resting equinus is the horse's tail, so you want to put these things together, so you want their foot in plantar flexion so it heals better. With subsequent splinting employed, gradual dorsiflexion towards neutral. Surgical repair allows for early range of motion. Next, the Weber ankle fracture classification. This is a way to classify ankle fractures on the basis of the lateral malleolus, the fibular bone. So normal, which is the Weber A. So Weber A is a fibular fracture below the syndesmosis. This will be the tibiofibular syndesmosis is intact, the deltoid ligament is also intact, and it's usually stable. And they could have plus or minus a medial malleolar fracture. A Weber B is a fibular fracture at the level of the syndesmosis. The tibiofibular syndesmosis is intact, or a mild tear, talofibular joint not widened, deltoid ligament intact or may be torn, and can be stable or unstable. And lastly, a Weber C is the fibular fracture above the mortise. Tibiofibular syndesmosis is torn, as well as widening of the talofibular joint. The deltoid ligament could be damaged, or the medial malleolar fracture. Unstable requires open reduction internal fixation. So from A to C, it gets progressively worse. And there will be a picture to depict this. Next, the Masonov fracture. This is a spiral fracture of the proximal third of the fibula associated with a distal medial malleolar fracture or rupture of the deep deltoid ligament. The proximal fibular fracture is a result of tearing of the distal talofibular syndesmosis and the interosseous membrane. Anyone with a distal ankle fracture should have a proximal film performed to rule out Masonov fracture. Next, the pylon fracture or tibial plafond. Fracture of the distal tibia with impact with the talus, an axial load, interrupting the ankle joint space, such as in a high impact trauma. The fracture extends into the ankle joint. Clinical manifestations: severe pain, swelling, and deformity. For management, open reduction and internal fixation. Next, stress fractures or a March fracture. Fracture due to overuse or high impact activities, such as athletes, military personnel, females at increased risk. Most common bones involved are the metatarsals. The third metatarsal is the most common. The tibia, fibula, also navicular bones. Clinical manifestations: insidious onset of localized aching pain, swelling and tenderness that increase with activity, localized bone tenderness at the fracture site. May develop pain with weight bearing as it progresses. Diagnosis: radiographs. 50% of radiographs will be negative initially, especially in the first 2 weeks, so it is mainly a clinical diagnosis. The radiographs may be positive with healing of the fracture and show a callus. MRI or bone scan usually only performed if radiographs are negative in high-risk areas, proximal fourth or fifth metatarsal, the navicular, talus, or patella, or if symptoms persist. For management, it's conservative, rest, avoidance of high-impact activities, ice, splint, or post-op shoe, analgesia. Orthopedic surgery may be needed for high-risk fractures such as the fifth metatarsal. Next will be plantar fasciitis. The mechanism is inflammation and microscopic tears of the plantar fascia due to overuse, especially in patients with flat feet, high arches, or heel spurs. Most common in females, 40 to 60, older, and obese patients. Clinical manifestations are inferior heel pain, often sharp, usually worse after periods of rest. The first few steps in the morning are the worst. Pain usually decreases throughout the day with gradual increased activity, walking, massage, stretching, and rest. May worsen towards the end of the day after prolonged weight bearing with a return of pain at night. On physical exam, there'll be local point tenderness to the underside of the heel, and pain increases with dorsiflexion of the toes. That's when you're stretching the plantar fascia. Diagnosis of plantar fasciitis, mainly clinical. Radiographs not useful for the diagnosis, as it's fascia, may show a flat foot deformity or a heel spur, osteophyte growing from constantly stretching the fascia. Management, starting off conservative with rest, ice, NSAIDs, heel and arch support, orthotics, also physical therapy, and plantar stretching exercises. Corticosteroid injections reserved for pain refractory to NSAIDs, and surgery in severe cases, or again refractory to conservative and corticosteroid injections. Next will be tarsal tunnel syndrome. This is a posterior tibial nerve compression as it travels through the tarsal tunnel. Compression may be a result of overuse, restrictive footwear, or edematous states. This is the medial side of the ankle, so pain is often having a differential diagnosis with a stress fracture there as well. Clinical manifestations, compression symptoms, altering pain and numbness at the medial malleolus, heel, and sole. Classically, the pain increases throughout the day and is worse at night with dorsiflexion, and pain does not improve with rest. Positive Tenniel sign, tapping at the tarsal tunnel. The posterior medial malleolus reproduces symptoms. And remember, Tenniel sign can also be done for an ulnar neuropathy as well as carpal tunnel. Diagnosis, clinical plus Tenniel sign at the tarsal tunnel, and electromyography, EMG, confirms the diagnosis. Management is conservative initially, rest, NSAIDs, properly fitted shoes and orthotics, corticosteroids if refractory, and surgical would also be refractory, tunnel release in severe cases. Next is a bunion or hallux valgus. Hallux valgus deformity at the first metatarsophalangeal joint with lateral deviation of the proximal phalanx. History of wearing properly fitted, tight, or pointed shoes is most common. Pes planus, flat feet, rheumatoid arthritis, and women. Clinical manifestations, pain over the great toe at the MTP joint with lateral deformity. Conservative, comfortable, wide-toed shoes. Surgical if no response to conservative management. So this is medial deviation of the distal phalanx and lateral deviation of the proximal. Hammer toe is next. Deformity of the PIP joint. Flexion of the PIP joint with hyperextension and hyperextension of the MTP and DIP joint. Seen if second, third, or fourth toe is longer than the first in people who wear tight-fitting shoes, OA, and RA. Hammer toe clinical manifestations are PIP pain due to contact with the shoes and PIP deformity. Next, neuropathic or Charcot arthropathy. This is joint damage and destruction as a result of peripheral neuropathy from diabetes, peripheral vascular disease, or other diseases. Pathophysiology of neuropathic arthropathy: decreased sensation, autonomic dysfunction, and repetitive microtrauma leads to bone resorption and weakening. Most commonly affects the midfoot and ankle. Neuropathic arthritis of the knee can also be seen with diabetes and tabes dorsalis, which is neurosyphilis, a form of neurosyphilis, tertiary syphilis. Clinical manifestations, it can be acute, non-tender, swollen, warm, erythematous joint, or chronic, where you see joint and foot deformity, alterations of the shape of the foot, ulcer, or skin changes. So remember, alterations in the shape of the foot with Charcot foot. Diagnosis by radiographs: obliteration of the joint space, fragmentation of bone, increased bone density, and disorganization of the joint. MRI or bone scintigraphy followed by indium scintigraphy may be needed in some cases to rule out osteomyelitis. Labs, usually associated with a normal white blood cell and inflammatory markers, but may have an elevated ESR. For management, conservative, rest, non-weight bearing, accommodative footwear. Surgical is rarely performed, may be indicated if severe deformity. Next, interdigital or Morton's neuroma. This is compression neuropathy of the interdigital nerve. Most commonly involves the second or third interdigital nerve between the metatarsal heads. The mechanism is repetitive microtrauma leading to degeneration and proliferation of the interdigital nerve. Risk factors, most common in women 25 to 50, especially if they wear tight-fitted shoes, high heels due to overpronation, and flat feet. Clinical manifestations of Morton's neuroma, lancinating or burning pain, especially with weight bearing, most commonly in the third intermetatarsal space, between the third and fourth metatarsals. Reproducible pain on palpation or squeezing the foot. May be associated with numbness or paresthesia of the toes or plantar aspect of the web space. For physical examination, they may have a palpable, painful mass near the tarsal heads. Also importantly, Mulder's sign, a clicking sensation when palpating the involved interspace while simultaneously squeezing the metatarsal joints. So palpating and squeezing is Mulder's. Diagnosis of Morton's neuroma, clinically, also ultrasound is an inexpensive method for detection, and MRI is definitive. Management, conservative, metatarsal support or pad, broad-toed shoes with firm soles are the first line. Glucocorticoid injection may be used if refractory to initial management, and surgical resection if failed conservative management. Complications of resection include permanent numbness or residual stump. Next, a Jones fracture. A Jones fracture is a transverse fracture through the diaphysis of the fifth metatarsal at the metaphyseal-diaphyseal junction. Mechanism may occur with ankle sprains or when the heel is off the ground while the forefoot is planted. Complications, 15 to 50% risk of non-union or malunion because it involves the vascular watershed area. So an area where it's basically only the combination of capillaries from larger veins. It doesn't have its own great arterial supply. So an increased risk of non-union or malunion with this Jones fracture on the fifth metatarsal. Manifestations will be pain over the fifth metatarsal area and lateral border of the midfoot, especially with weight bearing. Diagnosis will be radiographs, transverse fracture involving the metaphyseal-diaphyseal junction. Management is non-weight bearing in short leg cast for 6 to 8 weeks, followed by repeat radiographs, as it is often complicated by non-union or malunion. Frequently requires open reduction internal fixation as well as pinning. And next, there's also the pseudo-Jones fracture. This is a fracture through the base, the tuberosity, of the fifth metatarsal due to plantar flexion with inversion. This is more common but less serious than a true Jones fracture. Management for this is walking cast for 2 to 3 weeks, as opposed to a Jones, which was short leg cast for 6 to 8 weeks, and it was non-weight bearing. This is weight bearing, and you may need to do ORIF if displaced. So pseudo Jones is transverse avulsion fracture at the base of the tuberosity of the fifth metatarsal, whereas Jones is a transverse fracture through the diaphysis of the fifth metatarsal. Next, the Lisfranc injury. The Lisfranc joint are the bases of the first 3 metatarsal heads and their respective cuneiforms. A Lisfranc injury is injury where one or more of the metatarsal bones are displaced from the tarsus. Pathophysiology, disruption between the articulation of the medial cuneiform and the base of the second metatarsal, leading to a ligamentous injury, dislocation, and or a fracture, also known as a tarsometatarsal fracture dislocation. Mechanism, varied but includes rotational, midfoot, and severe axial load. Clinical manifestations: severe pain, inability to bear weight. Physical exam: swelling, bruising, tenderness over the tarso-metatarsal joint. Instability: dorsal subluxation with dorsal force to the midfoot. Radiographs: most common variant is one metatarsal away from the other. The flex sign, importantly, is a fracture at the base of the second metatarsal, which is pathognomonic for disruption of the tarso-metatarsal ligaments. May be associated with multiple fractures of the metatarsals, so that's the flex sign. Management is open reduction, internal fixation, followed by non-weight bearing for 12 weeks. So that's even longer than the Jones fraction, which we know was high risk of non-union malunion, which was non-weight bearing for 6 to 8 weeks. So Lisfranc is 12 weeks of non-weight bearing with ORIF. Next, we'll move into pediatric fractures. The green stick fractures first, which is an incomplete fracture with cortical disruption and periosteal tearing on the convex side of the fracture, leads to an intact periosteum on the concave side. So this is a bowing out, which is a green stick fracture. Next, the torus or buccal fracture, incomplete fracture with wrinkling or a bump of the metaphyseal-diaphyseal junction where the dense bone meets the more porous bone due to axial loading. So this is a buccal fracture. Salter-Harris classification of fractures, very important. Type 1 is isolated growth plate fracture, which may look normal. It has the best outcome. A type 2 is growth plate fracture plus fracture of the metaphysis, which also has a good prognosis. And type 2 is also the most common type of all Salter-Harris fractures. Type 3 is a growth plate fracture plus fracture of the epiphysis, which also has a moderately good prognosis. And type 4 and 5 had worse prognosis, with type 5 having the worst prognosis. Type 4 is a fracture extending across the metaphysis, growth plate, and epiphysis, needs reduction. Growth plate compression injury may arrest growth. This is the worst type for type 5. So an easy way to remember it is to put all type 1 through 5 out, 1, 2, 3, 4, 5, and also label it SALTR for Salter. So S is same, so it's basically same and straight through, S straight through. A, you could say, means above, so it's the fracture that's above the growth plate. L for lower, which is a type 3, which is below the growth plate. T, which is a type 4, which is through, so vertically through the growth plate. And 5 is R, Salter, and it's rammed, so it's rammed together. And this has the worst prognosis again, and leads to arrest of growth possible. SALTR, 1, 2, 3, 4, and 5. Next, malignant bone tumors. Osteosarcoma. Malignant tumor of osteoblastic proliferation. Most common primary bone malignancy in children and young adults. 90% occur in the metaphysis of the long bones. The distal femur most common. Proximal tibia and proximal humerus. Most common mets are to the lungs, which is the most common cause of death from the osteosarcoma. They have a bimodal epidemiology. Most common in adolescents, 80% occur under 20, and the second peak is 50 to 60 years old, especially if a history of Paget's disease of the bone or radiation therapy. For clinical manifestations of osteosarcoma, localized bone pain may occur after an injury and is much worse at night, importantly. Joint swelling without systemic symptoms, and physical exam yields a palpable soft tissue mass, maybe tender to palpation. For diagnosis, radiographs is first line. Hair on end or sunburst appearance, very important, hair on end or sunburst appearance due to the tumor spicules of calcified bone radiating in the right angle is classic, but not really specific. Other findings you might find mixed sclerotic and lytic lesions. Also importantly, Codman's triangle. This is ossification of raised periosteum. Can also be seen in Ewing sarcoma though. And you can also do an MRI. Biopsy is definitive diagnosis which you'll find malignant osteoid within the tumor and malignant sarcomatous stroma. For management, you want to do chemotherapy plus surgical removal with amputation if neovascular, or limb-sparing resection if not neovascular. Next will be chondrosarcoma. This is cancer of the cartilage itself, most commonly seen in adults age 40 to 75. Location is in the proximal femur, pelvic bones, and proximal humerus as most common sites. Clinical manifestations are localized pain and swelling, as well as pathologic fractures. Diagnosis is by radiographs. You'll see mineralized chondroid matrix with punctate or ring and arc appearance. Punctate or ring and arc appearance calcification. CT or MRI provides more details, and on histology, you'll see increased malignant cartilage matrix production. Management, surgical resection for non-metastatic chondrosarcoma, and chemo may be used in select advanced cases. Next will be Ewing sarcoma, second most common primary bone malignancy in children and young adults, after osteosarcoma, due to translocation between chromosomes 11 and 12, or rather 11 and 22. Most common in Caucasian males ages 5 to 25 years old. Bone, bone marrow, and lungs are the most common sites for metastasis. Lung mets are the most common cause of death. Location, 50% are found in the diaphysis of the long bone. Femur is the most common. Also pelvis, tibia, fibula, and pelvis. Clinical manifestations, localized bone pain and swelling that may be accompanied by systemic symptoms, fever, malaise, weight loss. On physical exam, they may have a palpable mass, local tenderness, or joint swelling. So classically on the radiograph, you'll see layered periosteal reaction or onion skinning appearance, lytic lesions with a moth-eaten appearance. So that's onion skinning and moth-eating. So just think moths and onions are gross, so ew. Codman's triangle, ossification of raised periosteum, can also be seen in osteosarcoma. Labs, increased ESR, leukocytosis. Histology, sheets of monotonous small round blue cells, may have pseudo-rosettes, circle of cells with central necrosis. Management, chemo, followed by limb-sparing resection when possible. Also radiation therapy when complete excision is not possible. Next, moving to benign bone tumors. So it's osteochondroma to start. This is cartilage-capped bony overgrowth arising from the external surface of a bone in areas of tendon insertion, proximal tibia, femur, and proximal humerus. Most common benign bone tumor, 10% may become chondrosarcomas. Most commonly seen between 20 and 10 years of age in males. Begins in childhood and until skeletal maturity. Clinical manifestations, painless, palpable mass, may develop symptoms of neurovascular compression. Diagnosis, radiographs, often pedunculated, narrow stalk that grows away from the growth plate and involves the medullary tissue. Biopsy is definitive. So that's pedunculated, grows away from the growth plate for osteochondroma. Management, observation if asymptomatic, but you can also do marginal resection, including a cartilage cap if it becomes painful or if located in the pelvis. The pelvic is the most common site for malignant transformation, usually delayed until skeletal maturity. Next, an osteoid osteoma. This is a benign bone tumor characterized by small radiolucent nidus, usually under 1 to 1.5 centimeters in diameter. Most commonly presenting in the second decade, more common in males. Locations are proximal femur most common, tibia, and remainder of the femur, and spine. Pathophysiology, the nidus produces high levels of prostaglandins, importantly. So if they have high levels of prostaglandins, you want to think osteoid osteoma. Clinical manifestations, progressively increased pain that is worse at night and unrelated to activity. The pain is relieved within 20 to 25 minutes with administration of NSAIDs, as these are prostaglandin inhibitors. May develop limb, localized tenderness, and limitation of range of motion. Diagnosis, Radiographs, small round lucency and nidus with a sclerotic margin. CT or MRI is more sensitive though. For management, NSAIDs with serial examinations or radiographs every 6 months. Untreated osteoid osteoma may spontaneously resolve over several years. Surgical resection for symptomatic lesions not responsive to conservative treatment. Next will be rheumatologic disorders. So moving from orthopedic and musculoskeletal to more rheumatologic disorders, and then back to some upper extremity pathology of the orthopedics. So first for rheumatologic will be fibromyalgia, a disorder characterized by abnormal pain perception of unknown etiology. This is most common in women ages 20 to 55. This clinical manifestations are chronic, widespread musculoskeletal pain, extreme fatigue, stiffness, sleep and cognitive disturbances, also called fibrofog, headache, neurologic symptoms such as numbness. Diagnosis, primarily a clinical diagnosis, but also associated with normal laboratory tests. Tenderness in at least 11 out of the 18 trigger points, plus chronic pain for over 3 months. So that's your diagnosis. So tenderness in 11 out of 18 trigger points over the body, chronic pain for over 3 months for fibromyalgia. Sleep studies show no REM cycle, so they're getting poor sleep as well. Management, conservative measures. Initial treatment involves a multidisciplinary approach, patient education, sleep hygiene, low-impact aerobic exercises such as swimming, water aerobics, walking, and biking. You can also do medical management with TCAs, tricyclic antidepressants, such as amitriptyline, which is a first-line medical management in patients not responsive to conservative measures. You can also do SSNRI, duloxetine, milnacipran. Cyclobenzaprine is an alternative if mild to moderate symptoms. Cyclobenzaprine is a muscle relaxant. Pregabalin is FDA approved for fibromyalgia as well, and especially helpful for sleep symptoms. So for treatment of fibromyalgia overall, TCAs such as amitriptyline first line, SNRIs like duloxetine, fluoxetine, cyclobenzaprine if mostly muscular, needs some muscle relaxant, and pregabalin if they're having trouble sleeping. Next, polymyalgia rheumatica. Idiopathic inflammation of the joints, bursa, and tendons, closely associated with giant cell arteritis, most common in over 50-year-old women. So remember, this is very common with giant cell arteritis. Clinical manifestations, pain and stiffness in the proximal joints and muscles, shoulder, hip, neck, pelvic girdle, worse in the morning for over 2 weeks. May also have difficulty combing hair and rising from a chair. So they have pain and stiffness, but they're not necessarily weak, as we'll see in another condition that's similar. Constitutional symptoms, low-grade fever, fatigue, and weight loss. Physical examination, normal muscular strength, no inflammation or objective weakness. May have decreased and active passive range of motion. Diagnosis by increased ESR and CRP, a normocytic normochromic anemia. Normal muscle enzymes, creatinine kinase and aldolase, distinguishes polymyalgia rheumatica from polymyositis, which is an important distinction, which is an autoimmune condition. Management, low-dose corticosteroids is the initial treatment of choice, and it's associated with a rapid response. Also, methotrexate an option if no response to corticosteroids or corticosteroids are contraindicated. And remember, for polymyalgia rheumatica, it has a close association with giant cell arteritis. So if they are having symptoms of the giant cell arteritis, like a sudden monocular vision loss, then you want to give the corticosteroids right away before you do the muscle biopsy for definitive diagnosis. But remember again, polymyalgia rheumatica, normal aldolase and creatinine kinase, and they're not necessarily having weakness, but they are having pain and stiffness. Next, rhabdomyolysis. This is an acute breakdown and necrosis of skeletal muscle. The etiologies are trauma, strenuous activity, prolonged immobility, crush injuries, seizures, cocaine, statin therapy especially, viral infections, and snake bites. Pathophysiology, Myoglobin from muscle breakdown is extremely toxic to the renal tubular cells, leading to acute tubular necrosis, ATN, acute kidney injury. Classic triad clinical manifestations are muscle pain and weakness or swelling, dark tea-colored urine, myoglobinuria. So remember, muscle breaks down into potassium, phosphate, creatinine, and myoglobin. So you can find these somewhere in the body or in the urine to determine if this is rhabdo. Diagnostic workup, an EKG is the most important initial test to look for signs of life-threatening hyperkalemia. So remember, potassium is more in the cell than outside of the cell in the serum. So if cells are breaking down, then they're releasing all that potassium, leading to an acute hyperkalemia. So I want to get the EKG for the first step in rhabdo. Urine, dipstick, and urinalysis. First lab tests ordered. A dipstick is positive for heme, but negative for red blood cells on microscopic examination of the urine. So this indicates myoglobin is spilling into the urine. Urine myoglobin is the most specific test. Also, muscle enzymes, you'll see increased creatinine phosphokinase, over 20,000, increased LDH, AST, and ALT. That's CPK, creatinine phosphokinase. Electrolytes, again, hyperkalemia, hyperuricemia, as cells have uric acid as well, hypocalcemia, hypophosphatemia, and increased creatinine, classic. Management, IV fluids are the first line and mainstay, with a target urine output of 0.5 to 1 milliliters per kilogram per hour. Treat the underlying cause. Also, osmotic diuretics such as mannitol or sodium bicarb for alkalinization of the urine may be added in some patients. EKG changes with hyper-K and you need to treat this with calcium gluconate to stabilize the cardiac membranes. Insulin with glucose also shifts the potassium intracellularly, which can be helpful too. And also short-acting beta agonists can be used in acute hyperkalemia. Next is polymyositis. This is an idiopathic autoimmune disorder leading to muscle inflammation, primarily involving the proximal limb, neck, and pharynx. May affect the heart, lungs, and GI tract as well. Most common in women 30 to 50 years of age. Pathophysiology is inflammatory myopathy due to CD8 plus lymphocyte infiltration of the endomysium. This is progressive symmetric proximal muscle weakness, especially the shoulders and hips. May have difficulty combing hair, raising the arms, rising from a chair, or climbing stairs due to this weakness. So this is a breakdown and a weakness. Systemic symptoms, dysphagia, polyarthralgias. Constitutionally, low-grade fever, fatigue, weight loss. On physical exam, decreased overall muscle strength, especially in the proximal muscles. And this is symmetrical due to muscle inflammation all over. Muscle atrophy may also be present. Not usually associated with a rash, helpful to distinguish from dermatomyositis. Diagnosis, increased muscle enzymes, creatine kinase and aldolase, are the best initial test, which helps differentiate it from polymyalgia rheumatica. Autoantibodies as well, anti-Jo1. This is the myositis-specific antibody often associated with interstitial lung fibrosis and mechanic hands, or hyperkeratotic palms with a dirty appearance. So anti-Jo, so I think myo, I think Jo. So anti-Jo is myositis. Anti-signal recognition protein, most specific for polymyositis and ANA. Increased ESR and CRP and rheumatic factor, normocytic normochromic anemia. Also an abnormal electromyography, EMG. Definitively, though, muscle biopsy is the test of choice, endomysial inflammation. So you want to do your muscle enzymes as the initial test, and definitively is a biopsy for polymyositis. Management, high-dose glucocorticoids are first line. Methotrexate, azathioprine, IVIG, mycophenolate can be used if no response to corticosteroids or if corticosteroids are contraindicated. So an exam tip here, polymyalgia rheumatica versus polymyositis, both can have hip and shoulder pain, difficulty rising from a chair, and combing their hair. However, polymyositis is decreased muscle strength on physical examination, symmetrical, proximal muscles weakened, reproducible on physical exam. That decreased muscle strength overall for polymyositis. and also elevated muscle enzymes, CK and aldolase, and an abnormal EMG. Polymyalgia rheumatica, on the other hand, will have normal muscle strength and normal muscle enzymes, no objective weakness. Next will be dermatomyositis, idiopathic autoimmune disorder leading to dermatologic manifestations plus muscle inflammation, primarily involving the proximal limbs, neck, and pharynx. May affect the heart, lungs, and GI tract, associated with cancer in 25% of the cases, lung, ovary, and GI. Pathophysiology. Inflammatory myopathy due to CD4 plus lymphocyte infiltration in the perimysium, perivascular involvement. So we said endomysium was for polymyositis, but dermatomyositis is perimysium. And also dermatomyositis is CD4, and polymyositis is CD8. Okay, dermatomyositis clinical manifestations. Progressive symmetric proximal muscle weakness, shoulders and the hips again. May have difficulty combing the hair, raising the arms, rising from a chair, and climbing stairs due to weakness. Systemic symptoms, dysphagia, polyarthralgias, low-grade fever, fatigue, weight loss. Physical examination, decreased muscle strength, especially in the proximal muscles, often symmetrical due to muscle inflammation. Again, muscle atrophy may be present. Importantly, you have Gutron's papules, which are raised violaceous scaly patches on the dorsum of the PIP and MCP joints. Also a heliotrope rash, edema and blue or purple discoloration of the upper eyelids. Malar rash, photosensitive poikiloderma, and shawl sign, erythema of the shoulders, upper chest, and back, or a V sign, erythema of the neck and upper chest. So these physical exam findings are very important for dermatomyositis. Again, the Gutron's papules, the heliotrope rash, and the shawl sign. Diagnosis, increased muscle enzymes, CK and aldolase are the best initial test. Again, anti-Jo1 myositis-specific antibody, often associated with interstitial lung fibrosis, and mechanic hands, the hyperkeratotic palms with a dirty appearance. You can also have, for dermatomyositis, anti-MI2, most specific for dermatomyositis, and an ANA positive. So again, ESR, CRP, rheumatic factor, normocytic, normochromic anemia, abnormal electromyography, and muscle biopsy is the definitive diagnosis, most accurate, and you'll see perifascial and perivascular inflammation. Management, high-dose glucocorticoids are first line, and also hydroxychloroquine is useful for skin lesions. And remember, with hydroxychloroquine, you need serial eye exams. Methotrexate, azathioprine, IVIG, mycophenolate can be used if no response to corticosteroids or if corticosteroids are contraindicated. Next, SLE, systemic lupus erythematosus. This is a chronic, systemic, multi-organ autoimmune disorder of connective tissues. Primarily a type 3 hypersensitivity reaction, which is antigen-antibody immune complexes. Risk factors are young females, onset of 20 to 40, African American, Hispanic, Native American, genetic, environmental, sun exposure, and estrogen. The classic triad is joint pain, fever, and malar butterfly rash, which is a fixed erythematous rash on the cheeks or bridge of the nose, sparing the nasolabial folds. Constitutional symptoms, fever, chills, fatigue, night sweats. Also discoid lupus, an annular erythematous patch on the face and scalp that heals with scarring. Systemic, CNS, headache, stroke, seizures, cardiovascular, glomerulonephritis, retinitis, oral ulcers, alopecia, and serositis. So another common mnemonic to remember the different manifestations of SLE is SOAP brain MD. So S is serositis, which you might have pericarditis or pleuritis. You'll have oral ulcers for O, aphthous, aphthous ulcers. A, arthritis and myalgias. Look for that ulnar deviation similar to RA. P, photosensitivity, a rash from the sunlight. B, for blood, you might have antiphospholipid syndrome, Raynaud's, other vascular phenomena. R for renal abnormalities, which is the most serious abnormality for people with SLE. A, ANA positive. I, immunologic findings like the anti-DS DNA, anti-Smith, anti-phospholipid antibody, and anti-Rho, which is neonatal lupus. N, which are neurosymptoms. M, which is a malar rash, which also spares the knuckles, which is helpful in differentiating for dermatomyositis. And discoid rash, which is a chronic cutaneous lupus. So for diagnosis of SLE, you can do the ANA, which is the initial screening of choice, which is most sensitive but not specific. Anti-double-stranded DNA and anti-Smith are pathognomonic and specific for SLE, but not sensitive. During flares, ds-DNA antibodies rise and complement decreases. So ds-DNA is used in monitoring. Antiphospholipid antibodies increase risk of arterial and venous thrombosis, such as atherosclerosis and DVTs. Includes anticardiolipin antibodies and lupus anticoagulant. Lupus anticoagulant is kind of a misnomer because it's not an anticoagulant, it's actually a coagulant. Pancytopenia, anemia of chronic disease, which is most common, hemolytic anemia, leukopenia, lymphopenia, and thrombocytopenia. Decreased complement levels, C3 and C4. Management. Management choice depends on the level of organ involvement of SLE. Sunscreen and avoidance of prolonged sun exposure in all patients. Mild lupus, such as skin, joint, and mucosal, you can start off with hydroxychloroquine with or without NSAIDs and a short-term use of low-dose glucocorticoid. And in mild cases, NSAIDs may just be used alone. For moderate, significant, but not organ-threatening, hydroxychloroquine, again, watch the eyes, chloroquine plus short-term glucocorticoid. Severe, life or organ-threatening, you can use high-dose glucocorticoids or intermittent IV pulses of methylprednisolone with other immunosuppressive agents like cyclophosphamide, mycophenolate, rituximab. Belimumab, which is last line, is a monoclonal antibody that inhibits B lymphocyte stimulator binding to the B cells, which inhibits B cell survival. It was specifically designed for SLE and usually reserved for active cutaneous or musculoskeletal disease, unresponsive to glucocorticoids or other immunosuppressive agents. Next, drug-induced lupus. Drug-induced lupus is an autoimmune disorder similar to SLE caused by the use of certain drugs. So hydralazine, procainamide, isoniazid, and quinidine are the most common. How this is remembered is HIP-Q, HIP-Q, hydralazine, isoniazid, procainamide, and quinidine. There's also some other ones like methyldopa, minocycline, chlorpromazine, pyrazinamide, D-penicillamine, carbamazepine, phenytoin, and minoxidil. Clinical manifestations, SLE-type symptoms, rash, fever, arthralgias, arthritis, serositis, which is pleuritis and pericarditis. Unlike SLE, it is not associated with alopecia, hematologic, kidney injury, or CNS symptoms. And importantly for this one, anti-histone antibodies are hallmark. So histone for drug-induced lupus. Also a hypocomplementemia, low C3 and C4. And ds-DNA are not usually seen, as they would be seen in regular SLE. And of course, the management is discontinuation of the offending agents and NSAIDs for arthralgias and serositis. Topical corticosteroids for cutaneous symptoms. Next, antiphospholipid syndrome. This is an idiopathic disorder characterized by venous or arterial thrombosis due to antibodies against negatively charged phospholipids. Can occur as a primary disease or in the setting of other diseases, especially SLE. Pathophysiology: the autoantibodies activate complement-mediated thrombosis. Triggers: smoking, prolonged immobilization, and estrogen, oral contraceptive use, pregnancy, postpartum period, hormonal replacement therapy. Malignancy, hyperlipidemia, and hypertension. Clinical manifestations: increased risk of arterial and venous thrombosis, atherosclerosis, recurrent DVT or PE, and recurrent miscarriages, importantly. Livedo-reticularis, valvular heart disease, and neurologic symptoms, stroke, TIA, cognitive effects. So remember, recurrent miscarriages for antiphospholipid, and also factor V Leiden can have recurrent miscarriages as well. Diagnosis, you'll find anti-cardiolipin antibodies associated with false positive testing for syphilis, importantly, positive RPR or VDRL with a negative confirmatory FTA-AVS because the screening test contains cardiolipin, may have a normal or slightly prolonged PT, prothrombin time. Lupus anticoagulant has an increased partial thromboplastin time, PTT, but associated with thrombosis. So despite its name, lupus anticoagulant positively is associated with hypercoagulability. Beta-2 glycoprotein 1 autoantibodies. Also mixing studies. Failure to correct PTT after mixing. After mixing the patient's blood with normal plasma due to the presence of an inhibitor, unlike clotting deficiency disorders where the mixing study will correct the APTT. Prolonged Russell Viper venom test. Most specific for lupus anticoagulant. Official diagnosis requires 2 positive results with samples taken at least 12 weeks apart. Management of antiphospholipid. Asymptomatic patients do not need to be treated. Recurrent thrombosis may require lifelong warfarin or a NOAC, novel oral anticoagulant, but warfarin is more effective long term. Low molecular weight heparin may be used in patients that are pregnant to prevent fetal loss. Next will be Sjogren's syndrome, an autoimmune disease primarily affecting the exocrine glands, the salivary and lacrimal glands. Primary occurs alone, and secondary associated with other autoimmune disorders like Hashimoto's thyroiditis, SLE, rheumatoid arthritis. Sjogren's syndrome most common in females, 90%, 40 to 60 years old, and HLA-DR5-2. Clinical manifestations, dry mucous membranes, especially dry mouth, dry eyes, vaginal dryness, bilateral parotid gland enlargement, and dental caries, which is a combination of xerostomia, or dry mouth, so the saliva glands need to increase production. Diagnosis, screening labs. You'll have an ANA, specifically anti-SSA, RO, and anti-SSB, LA. So anti-RO and LA are the best initial laboratory tests. Positive Schreimer test, decreased tear production, wetting of under 5 millimeters of the filter paper placed in the lower eyelid for 5 minutes. So a decreased wetness because they're having decreased secretions. You can also do the Rose-Bengal stain, abnormal corneal epithelium. Definitive diagnosis is lip or parotid gland biopsy with gland fibrosis and lymphocytic infiltration, and nonspecific labs like positive rheumatic factor, anemia, and leukopenia. Lifestyle management, increase mucus secretions, artificial tears to prevent corneal ulcers, increase fluid intake, sugar-free gum, artificial saliva, and fluoride treatments. Cholinergic drugs, pilocarpine or cevimeline to increase secretions. Remember, increasing the parasympathetic increases your sludge, salivation, lacrimation, urination, defecation, GI. Increased risk of non-Hodgkin's lymphoma in these patients. Pneumonitis, interstitial nephritis. Increased risk of congenital heart block if the mother has a high antibody titer while pregnant. So as you see with this one, Sjogren's syndrome has an increased risk of NHL, non-Hodgkin's lymphoma, and remember, dermatomyositis has a 25% cancer associated with it. So to go over pilocarpine, this is a cholinergic or muscarinic drug that increases salivation and lacrimation. Indications are in Sjogren's syndrome to improve dry mouth and dry eyes, also topical in acute angle closure glaucoma, which causes pupillary constriction and opening the angle. Adverse effects, diaphoresis, flushing, sweating, bradycardia, diarrhea, nausea, vomiting, incontinence, blurred vision, and again your sludge, salivation, lacrimation, urination, defecation, GI, so digestion, and constriction of the pupils. Next will be scleroderma, or systemic sclerosis. This is a systemic autoimmune connective tissue disorder where collagen deposition leads to fibrosis of the skin and internal organs, lung, heart, kidneys, GI tract, most common in women 30 to 50 years old. Types, limited crest syndrome is 80%, characterized by tight, shiny, thickened skin involving the face, neck, as well as distal to the elbows and knees. Importantly, distal to the elbows and knees. Spares the trunk. Pulmonary hypertension with advanced disease. And this CREST syndrome stands for calcinosis cutis, Raynaud's phenomena, which are the red, white, and blue vasospastic changes of the digits. E, esophageal dysmotility. S, sclerodactyly, like a claw hand. And T, telangiectasias. Diffuse scleroderma, so this is the anti-SCL70, where the anti-centromere was CREST. So CREST C, anti-centromere C, and diffuse is anti-SCL70, scleroderma. Tight, shiny, thickened skin involving the trunk and proximal extremities, associated with a greater internal organ involvement, such as restrictive lung disease due to pulmonary fibrosis and myocardial fibrosis. For diagnosis, anti-centromere antibodies associated with limited CREST-specific syndrome, anti-SCL70 antibodies, which is also the anti-topoisomerase, associated with diffuse disease and multiple organ involvement, a poorer prognosis than limited. ANA, nonspecific, but positive in 90% of patients with scleroderma. And for management, treatment is organ-specific. So GERD, you use PPIs. Hypertensive renal disease, ACE inhibitors to dilate the efferent. Raynaud's, vasodilators, calcium channel blockers. Prostacyclin, which is a prostaglandin analog. Severe, you can use DMARDs, methotrexate, mycophenolate, cyclophosphamide. Pulmonary fibrosis, cyclophosphamide. Pulmonary hypertension, bosentan, sildenafil, prostacyclin analogs. Next, Behçet syndrome. How I remember this is OGO. Oral ulcerations, genital ulcerations, and ocular changes. OGO. Behçet syndrome. Multisystemic autoimmune disorder characterized by recurrent, painful oral and genital ulcers, erythema nodosum, and uveitis, conjunctivitis of the eye, arthritis, and CNS involvement, may mimic multiple sclerosis. Increased incidence in Asian or Middle Eastern or Mediterranean people. Initial presentation is 20 to 40 years old. Primary clinical diagnosis, biopsy is definitive, seeing leukocytoclastic vasculitis or lymphocytic vasculitis, increased ESR, CRP, leukocytes. Also with Behçet's, you have pathergy, which is sterile skin papules or pustules from minor trauma, such as a needle stick, and this is less common in patients from North America or Northern Europe. Management, corticosteroids during flares. Other treatment options include colchicine, cyclophosphamide, azathioprine. For Behçet's overall, I've just seen questions involving the oral, the ocular, and the genital ulcerations. Also know this is HLA-B5, and they can have arthritis as well. Next, Takayasu arteritis. Chronic large vessel vasculitis that affects the aorta and its primary branches, the aortic arch and pulmonary arteries. Risk factors are women, 80 to 90%. Age of onset is 10 to 40 years, and in Asians. Clinical manifestations, constitutional symptoms, flu-like weight loss, low-grade fever, fatigue, and arthralgias. Vessel ischemia, coronary arteries, carotid arteries, TIA, stroke, renal arteries, hypertensive crisis, subclavian artery, arm claudication, lower extremity claudication, and aneurysm rupture. On physical exam, there'll be bruits, carotid, subclavian, or abdominal, diminished pulses, asymmetric blood pressure measurements between the arms, greater than 10 millimeters of mercury difference, hypertension, symptoms of peripheral arterial disease. Diagnosis is by angiography, MRA, or CTA, necessary to confirm the diagnosis and extent of the disease. Also nonspecific may have elevated increased ESR, CRP, normocytic, normochromic anemia, leukocytosis. High-dose corticosteroids is first line. Also methotrexate, azathioprine, revascularization in some. Next, Kawasaki syndrome. Medium and small vessel necrotizing vasculitis, including the coronary arteries, aka mucocutaneous lymph node syndrome. The pathophysiology is thought to be an unidentified respiratory agent or viral pathogen with a propensity towards vascular tissue. Risk factors,
This is most common, importantly, in children under 5, boys, and Asians, who are at the highest risk. And diagnosis is by warm plus cream. So warm, fever over 5 days, plus 4 of 5 of the following: conjunctivitis, rash, erythematous or morbilliform or macular. E, extremity changes, edema, erythema, or desquamation of the palms and soles. Also Bowes lines, transverse nail grooves, and arthritis. A, adenopathy, cervical. M, mucositis, a strawberry tongue, lip swelling, fissures, or pharyngeal edema. So that's your warm plus cream. So that's fever of over 5 days plus 4 of 5 of the following. Labs, nonspecific, elevated white blood cells and platelets, anemia, ESR, CRP, sterile pyuria. Echocardiogram and EKG are not recommended to look for complications. Complications include, importantly, coronary vessel arteritis, coronary artery aneurysm, myocardial infarction, pericarditis, and myocarditis. Management is IV immunoglobulin, IVIG, plus aspirin for fever, joint pain, and prevention of coronary complications. So this is only the only indication for aspirin in kids, where it's more important to treat these Kawasaki syndrome patients than it is to worry about Reye's syndrome, which could result from aspirin use in kids. So that's IVIG and aspirin to decrease coronary artery aneurysm risk. Next, polyarteritis nodosa, PAN, PAN. Systemic vasculitis, primarily of the medium-sized vessels, most commonly affects the renal, CNS, and GI. Pulmonary vessels, lungs not involved, and this helps distinguish PAN from other vasculitides. Pathophysiology, type 3 hypersensitivity reaction leads to ischemia and microaneurysms of the affected vessels. Most common in men 40 to 60 years of age. Increased association with hepatitis B and C. Some say it's called, quote-unquote, the hurting syndrome. Clinical manifestations: renal hypertension, renal artery stenosis, renal ischemia. Polyarteritis nodosa is not associated with glomerulonephritis. Abdominal pain worse with eating, intestinal angina, nausea, vomiting. Constitutional symptoms, CNS. You see the mononeuritis multiplex, importantly, and also dermatologic livido-reticularis. So highlighted are association with chronic hep C and B, hypertension of the kidneys, mononeuritis multiplex, livido-reticularis. Also for diagnosis, classic polyarteritis nodosa is ANCA negative. So no positive P or C ANCAs in polyarteritis nodosa. Renal or mesenteric angiography, microaneurysms with abrupt cutoff of small arteries or beading. Biopsy, definitive, necrotizing medium vessel vasculitis and no granulomas. Management, glucocorticoids, cyclophosphamide additive severe or refractive. And you also want to treat hepatitis B patients as well if they have this. Next, eosinophilic granulomatosis with polyangiitis, EGPA, also known as Churg-Strauss syndrome. So again, a systemic small and medium vessel granulomatous necrotizing vasculitis can be a rare side effect of Montelukast. Lungs most commonly organ involved, unlike PAN, also followed by the skin. So you have the triad here for Churg-Strauss eosinophilic granulomatosis is asthma, eosinophilia, and chronic rhinosinusitis. So asthma, eosinophilia, chronic rhinosinusitis. You have a prodrome phase of atopic disease, allergic rhinitis, and asthma in over 90%. There's an eosinophilic phase where eosinophils infiltrate the organs like skin, lung, GI tract. You could have some cutaneous nodules, pulmonary opacities, abdominal pain, etc. Vasculitic phase as well with constitutional symptoms. Importantly for diagnosis, of course, there'll be an eosinophilia and a P-ANCA positivity, which is hallmark. Increased ESR, CRP, IgE, and rheumatic factor. But P-ANCA and eosinophilia are hallmark. Remember the triad: asthma, eosinophilia, chronic rhinosinusitis. Management, glucocorticoids, and you can add cyclophosphamide if severe. Next, similarly, GPA, granulomatosis with polyangiitis, also known as Wegener's granulomatosis. Small vessel vasculitis with granulomatous inflammation and necrosis of the nose, lungs, and kidneys. Importantly, the nose. Triad, upper respiratory tract, lower respiratory tract, and glomerulonephritis. Upper respiratory tract and nose. Note nasal congestion and, importantly, a saddle nose deformity with Wegener's saddle nose deformity, nasal perforation, mastoiditis, otitis media, and refractory sinusitis. The lower respiratory tract, like cough, dyspnea, hemoptysis. Glomerulonephritis, also rapidly progressive glomerulonephritis, crescent seen on biopsy. So that's that rapidly progressive glomerulonephritis with crescent shape. You'll see hematuria, red blood cell casts. And granulomatous with polyangiitis is a C ANCA positivity. How I remember that is C is basically a G, just G has the extra part of the letter, so it looks very similar. So C ANCA positivity with granulomatous or Wegener's polyangiitis. So that's the best initial test, to do a C ANCA. And you can also do a biopsy, which is definitive, lungs preferred over the sinus or kidney. And you see large necrotizing granulomas. Management, glucocorticoids plus cyclophosphamide again. And lastly, microscopic polyangiitis, MPA, small and medium vessel vasculitis, not associated with nasopharyngeal symptoms, necrosis, granulomatous inflammation, as seen with GPA, affects the capillaries, capillary involvement, not seen with PAN. Clinical manifestations, constitutional, you'll have constitutional symptoms plus palpable purpura, and again, mononeuritis multiplex. But those palpable purpura are microscopic polyangiitis. Lung and renal involvement, again, rapidly progressive, just like Wegener's. Acute glomerulonephritis, that's rapidly progressive and crescentric. Diagnosis is by a positive P ANCA, so polyangiitis, P ANCA. Chest x-ray, nonspecific, biopsy as well. And management, glucocorticoids plus cyclophosphamide. So P ANCA for polyangiitis, microscopic that is, MPA. And C ANCA looks like granulomatosis with polyangiitis, which is Wegener's. So glucocorticoids plus cyclophosphamide are used in the following diseases: microscopic polyangiitis, granulomatosis with polyangiitis, which is Wegener's, eosinophilic granulomatosis with polyangiitis, which is Churg-Strauss, systemic lupus nephritis, PAN, polyarteritis nodosa, and rapidly progressive glomerulonephritis, which is those crescentric shapes on the kidneys. And to briefly go over giant cell temporal arteritis, the incidence is older women over 50. Pathophys is cranial arteries. The temporal and ophthalmic artery are involved. They may have headache, visual loss, and jaw claudication, temporal artery symptoms. Diagnosis is by temporal artery biopsy, but importantly, that's a clinical diagnosis as well. If you have a high suspicion, do not suspend the treatment, which is high-dose glucocorticoids, before doing the biopsy, although biopsy is definitive. Okay. So next will be HSP, Henoch-Schönlein purpura. This is an immunoglobulin A vasculitis. So acute systemic IgA-mediated small vessel vasculitis. 90% occur in children between 3 and 15 years of age. Occurs after an infection, usually URI or group A beta hemolytic strep or parvovirus B19. So the clinical manifestations are 4 cardinal symptoms. Also use the mnemonic HSPA, Henoch-Schönlein purpura, and it's an IgA vasculitis. So H, hematuria, increased BU1 creatinine proteinuria. S, synovial, arthritis and arthralgias. P, palpable purpura, especially in the lower extremities. And A, abdominal pain and IgA vasculitis. Diagnosis, clinical, also normal PT, PTT, and platelets. The purpura is due to vasculitis, not due to thrombocytopenia or coagulopathy, importantly. Kidney biopsy, you might see mesangial IgA deposits. And management, supportive treatment is the mainstay. Bed rest, hydration, and NSAIDs for pain, self-limited. So remember that normal PT, PTT, and platelets, so usually, and no thrombocytopenia as you would normally see. However, the PREP is due to a vasculitis. Next, anti-GM antibodies, or glomerular basement membrane antibodies, also known as Goodpasture's disease. This is a type 2 hypersensitivity reaction. IgG antibodies against type 4 collagen in the alveoli and the glomerular basement membrane of the kidney, so G4, H, and H. Hemoptysis, hematuria, glomerular basement membranes, type 4 collagen. Symptoms limited to the lungs and the kidney. Lungs, hemoptysis, dyspnea, dry cough. Kidneys, hematuria, oliguria. Systemic symptoms of vasculitis are usually absent. Diagnosis, glomerulonephritis, increased BUN, creatinine, urinalysis, hematuria, proteinuria, dysmorphic red blood cells, and RBC casts, importantly. Positive anti-GBM antibodies are the best initial test after urinalysis. So urinalysis, you see the red blood cells and casts, and then you get the anti-GBM antibodies, which are positive. May have anemia, chest radiographs often abnormal but nonspecific. Biopsy of the glomerulus or alveoli is definitive. And the biopsy may show linear IgG deposits on immunofluorescence. Crescentric, rapidly progressive glomerulonephritis. Management, glucocorticoids plus cyclophosphamide plus plasmapheresis. Think Goodpasture's. G, glomerulonephritis, which is rapidly progressive. P, pulmonary hemorrhage and hemoptysis. Next, seronegative spondyloarthropathies. These are joint diseases affecting the vertebral column associated with rheumatic factor and ANA negativity. Risk factors, most common in young males, under 40 years of age at initial presentation, and HLA-B27 positivity. So rheumatic factor and ANA negative, but HLA-B27 positive. Characterized by vertebral column involvement, sacroiliitis, uveitis, and enthesitis, inflammation at the site of attachment of a tendon or ligament to the bone. So how you can remember it is PAIR, P-A-I-R. So P, psoriatic, A, spondylitis, ankylosing spondylitis, I, IBD, R, reactive arthritis. So first starting off with psoriatic arthritis. This is inflammatory arthritis in patients with psoriasis. Incidence, 15 to 20% of patients with psoriasis will develop psoriatic arthritis. 80% will have psoriasis preceding the arthritis by months to years. Clinical manifestations, arthritis, joint stiffness, may be asymptomatic, symmetric, or clinically indistinguishable from RA, but unlike RA, may involve the DIP joints. Dactylitis, sausage digit hands over the feet, sacroiliitis, and chronic uveitis. Psoriasis, you'll see erythematous plaques with thick, silvery, white scaling and nail pitting. Radiographs are diagnostic, best initial test, and you'll see the classic pencil and cup deformity, which is a description of the appearance of the periarticular bony erosion and bony reabsorption. The bony erosions look thin at the end of one bone being inserted to another thicker bone, similar to that in a pencil cup. Management, NSAIDs their first line, but for severe psoriatic arthritis, methotrexate is the drug of choice, such as in severity, which is over 5 joints, severe damage on radiographs, or no response to NSAIDs. Also, leflunomide is an alternative. TNF inhibitors used if methotrexate is unsuccessful, like adalimumab or infliximab. Interleukin antagonists, if refractory to anti-TNF agents. So again, sausage digits, pencil and cup deformity, that dactylitis, and psoriasis with the thick silvery scale and nail pitting. Enteropathic arthritis, which is associated with IBD like Crohn's and ulcerative colitis. Ankylosing spondylitis, chronic inflammatory arthropathy of the axial skeleton, spine, and sacroiliac joints with progressive spine stiffness. Ankylosis equals stiffness of the joints due to fusion of the joints. The risk factors are young males, 15 to 30 years old, HLA-B27 positivity, So very important, young males for ankylosing spondylitis. Clinical manifestations, back pain, stiffness, and decreased range of motion that is worse in the morning with rest and decreases with exercise and activity. Kyphosis, sacroiliitis, and large joint arthritis. Extra-articular, Achilles tendon enthesitis, dactylitis, uveitis, and also cardiac changes. AV cardiac blocks, aortic regurg, and pulmonic fibrosis, decreased chest expansion. Diagnosis is an increased ESR and a negative rheumatoid and ANA. On radiographs of the SI joint, often initial test ordered, and you'll see that sacroiliitis with this ankylosing spondylitis, narrowing of the joint, early finding. And the classic bamboo spine, straightening of the spine, loss of normal lumbar curvature, and squaring of the fusions of the vertebrae by bridging syndesmophytes, but a classic finding. This, however, is rare. MRI, most accurate test. Management is NSAIDs, exercise program, and physical therapy, and anti-TNF drugs if no response to NSAIDs, like etanercept, adalimumab, and infliximab. Next will be reactive arthritis. Reactive arthritis, a reaction to something else, like a GI bug or chlamydia. Inflammatory arthritis in response to an infection or inflammation in another part of the body, formerly Reiter's syndrome. May be seen 1 to 4 weeks after chlamydia trachomatis or a GI infection, salmonella, shigella, campylobacter, or yersinia. HLA-B27 is associated with increased incidence. So how I remember this one is CUA. Conjunctivitis, urethritis, and arthritis. CUA. Triad, arthritis plus ocular symptoms, conjunctivitis, uveitis, plus genital, urethritis, cervicitis, balanitis. Lower extremity joints most commonly affected, especially the knees, and also note keratoderma blennoragicum is a hyperkeratotic lesion of the palm and soles. Diagnosis, arthrocentesis to rule out septic arthritis. Findings in reactive arthritis are similar to other inflammatory arthritides. Increased white blood cell count, but under 50,000. Predominantly neutrophils with negative cultures. No evidence of septic arthritis. You also have non-specific findings like an increased ESR and IgG, also a normal chromic anemia. Management, NSAIDs are first line. Sulfasalazine or methotrexate is second line treatment if no response to NSAIDs. Intra-articular joint injections may also be used as a second line agent. Antibiotics do not reverse reactive arthritis once the joint pain has begun, but may be indicated to treat the underlying cause, chlamydia trachomatis. So for tumor markers, just to go over some different tumor markers and what the associations with those are. So AFP, or alpha-fetoprotein, associated with hepatocellular carcinoma, non-semitomatous germ cell testicular cancer, decreased in Down syndrome, so remember your quad screen, your HCG, alpha-fetoprotein, inhibin A, and unconjugated estriol. AFP is down in Down syndrome. So beta HCG, again, non-semitomatous germ cell testicular cancer, choriocarcinoma, teratomas, and also trophoblastic tumors like high densitiform mole. CA125, ovarian cancer. CA19-9, pancreatic cancer. Also GI, colorectal, esophageal, hepatocellular carcinoma. But mostly for 19-9, it's pancreatic. Calcitonin, medullary thyroid cancer, because as the parafollicular cells of the thyroid secrete calcitonin. CEA, colorectal cancer. Medullary thyroid, pancreatic, gastric, lung, breast cancers as well, mostly colorectal. PSA, prostate-specific antigen, prostate cancer, also slightly elevated in BPH and prostatitis. Next, arthritis syndromes. First, gout. Gout is uric acid deposition in the soft tissues, joints, and bones. 90% occur in men. Etiologies, renal uric acid underexcretion is 90%. Can be worsened with renal insufficiency, thiazides, aspirin, also uric acid overproduction, increased cell turnover, like cancer from tumor lysis syndrome increases uric acid, chemotherapy again, and hemolysis. So how I remember it is DAN, D-A-N, diuretics like HCTZ, A, aspirin, ASA, and nitrites, N, and niacin as well, actually, for N, D-A-N. Attacks associated with purine-rich food are the triggers: alcohol, liver, seafood, and yeasts, causing rapid changes in uric acid concentrations. Meds, again, thiazides and other diuretics, pyrazinamide, ethambutol, aspirin. Notable exception is losartan, so the only one that doesn't increase uric acid is losartan of the ARBs. All the other diuretics decrease it, or rather increase uric acid levels. Clinical manifestations: acute gouty arthritis. The first MTP joint of the great toe is most common, also called podagra, and lower extremity, knees, feet, and ankles. Severe joint pain, erythema, warmth, swelling, and tenderness, also fever. Diagnosis by arthrocentesis is the diagnostic test of choice. Negatively bifringent, needle-shaped crystals. Increased white blood cell count, but under 50,000, and predominantly neutrophils. On radiographs, you'll have the mouse or rat bite lesions, which are punched out erosions with sclerotic or overhanging margins. Tophi may be seen in long-standing disease. Increased ESR and white blood cells. Acute management or attacks of gout. NSAIDs are the initial treatment of choice. Avoid aspirin. Corticosteroids reserved for refractory to NSAIDs, or if NSAIDs are contraindicated, such as in renal disease. Can be injected into a single joint or given as oral therapy. Colchicine, usually reserved if unable to use NSAIDs or corticosteroids. Adverse effects include diarrhea and bone marrow suppression, neutropenia. Chronic management, prophylaxis of gout. Lifestyle, decreased alcohol consumption, especially beer. Weight loss, decreased high purine intake, like meats and seafoods. Also allopurinol is first line, and febuxostat are xanthine oxidase inhibitors, so they decrease uric acid production. Not started during acute attacks, importantly. Allopurinol is safe in renal insufficiency. And also remember, allopurinol can be a cause of erythema multiforme as well. There's also uricosuric drugs, which are probenecid. Both are contraindicated in renal insufficiency, and also colchicine. So there's two things you can do for gout, for chronic. You can decrease the production of the uric acid or increase the secretion. So the uricosuric drugs like probenecid increase the secretion. Allopurinol and febuxostat decrease the production. Next, for acute gout management, you have NSAIDs, which are naproxen and indomethacin. The mechanism is anti-inflammatory, and they're superior to colchicine. Indications: initial management of choice for acute gout, especially in patients under 60 years of age, without any significant cardiovascular, renal, or active GI disease, and also avoid aspirin. Contraindications: renal insufficiency. Corticosteroids, or glucocorticoids rather. The mechanism is anti-inflammatory, can be administered intra-articularly or orally. Indications: acute gout refractory to NSAIDs, or if NSAIDs are contraindicated, again, such as severe renal disease. Caution for glucocorticoids: using caution with patients with glucose intolerance, as it can raise the blood glucose, heart failure, and poorly controlled hypertension. Colchicine mechanism is anti-inflammatory. Patients who cannot use either NSAIDs or glucocorticoids, you want to go with colchicine. Safe in mild renal injury, the only medication that can be used in both acute and chronic gout. And you must start colchicine quickly, under 24 to 36 hours from when the attack starts. Chronic gout management. Allopurinol. Mechanism: xanthine oxidase inhibitor. Leads to decreased uric acid production. Indicated as first-line prophylaxis for gout. Again, not used for acute attacks. Prevents urate nephropathy from tumor lysis syndrome as well. Allopurinol safe in patients with renal insufficiency. Adverse effects: hypersensitivity, rash, hemolysis, SJS importantly, also erythema multiforme, allergic interstitial nephritis. Febuxostat is another xanthine oxidase inhibitor. So you should know some other drugs that can cause Steven Johnson and erythema multiforme like herpes, phenytoin, mycoplasma, phenobarbital, and of course this allopurinol here. Colchicine. Mechanism is an anti-inflammatory, impairs neutrophil chemotaxis. Patients who cannot use either NSAIDs or glucocorticoids can use colchicine as chronic management. Safe in mild renal injury, the only medication that can be used in acute and chronic gout. Adverse reaction, neutropenia, GI irritation. For uricosuric drugs, probenecid, sulfenperazone. Mechanism, increase urinary uric acid excretion, uricosurics. Indications, prophylaxis for gout, used in uric acid under excretors. Adverse effects, uric acid calculi can cause prolonged penicillin levels. Contraindications of probenecid, renal insufficiency, prior history of uric acid renal calculi. And there's also pegloticase, which dissolves uric acid itself. It's a recombinant uricase, a catalyzing enzyme, metabolizes the uric acid to allantoin, which is more water-soluble. Indications are prophylaxis for gout. Adverse effects, increased risk of new gout flare. So this is not used in acute attacks at all. Next, moving to calcium pyrophosphate dihydrate deposition disease, or CPPD. Calcium pyrophosphate dihydrate deposition in the joints and soft tissues, leading to inflammation and bone destruction. Risk factors are hemochromatosis, hyperparathyroidism due to the increased calcium, and hypomagnesemia. Joints involved are the knees most commonly, but also could be the elbows, wrists, and MCP joint. Clinical manifestations, usually asymptomatic, and you might find an incidental finding of chondrocalcinosis on radiographs. Acute calcium pyrophosphate disease, crystal arthritis, is also called pseudogout, which is clinically indistinguishable from gout, with severe joint pain, erythema, warmth, swelling, and tenderness. Pseudo-RA as well could mimic RA with inflammation, joint pain, and morning stiffness, as well as pyrophosphate arthropathy, resembles osteoarthritis. Diagnosis of pseudogout, arthrocentesis, is the diagnostic test of choice. You'll find positively birefringent, as opposed to gout, which is negatively, rhomboid-shaped calcium pyrophosphate crystals, and an increased white blood cell, 2,000 to 50,000, primarily neutrophils. On radiographs, there'll be linear calcifications of cartilage, again known as chondrocalcinosis. Pseudogout management, corticosteroids are first line, intra-articular corticosteroid of 1 or 2 joints, oral if it's over 2 joints. NSAIDs are first line option if over 2 joints as well. Contraindications include renal insufficiency, active peptic ulcer disease, GI bleed, as well as cardiovascular such as heart failure or uncontrolled hypertension, or anticoagulant use. Colchicine can also be used. This is a first line option that can be used in acute and chronic CPP disease, can be used in prophylaxis between acute attacks as well. Prophylaxis, colchicine can be used in patients with 3 or more attacks of the pseudogout annually. Next, juvenile idiopathic arthritis, also known as juvenile idiopathic rheumatoid arthritis. Autoimmune, mono or polyarthritic arthritis in children under 16 years old or over 6 weeks. So over 6 weeks it has to be in children under 16 years old. There's 3 types: the systemic Still's disease, there's also the posse, oligo-articular, and the polyarticular. So for systemic Still's disease, this is daily or diurnal high fever, daily arthritis, salmon-colored pink migratory rash. So 2 keywords, diurnal high fever and salmon-colored pink migratory rash. No iridocyclitis, but associated with systemic symptoms like hepatosplenomegaly, lymphadenopathy in 20% of the cases. Posse or oligo-articular juvenile idiopathic arthritis is under 5 joints involved. This most commonly affects the medium to large joints, and they do have iridocyclitis, which is an anterior uveitis in 50% of all cases. So that's the oligo-articular. Then polyarticular is 5 or more small joints, usually symmetric, most similar to adult RA, including morning stiffness. And this one again does have iridocyclitis in the anterior uveitis and has a worse prognosis if rheumatic factor is positive. So the posse oligoarticular has the anterior uveitis, but it's under 5 joints, and polyarticular, meaning many, has over 5 joints as well as the anterior uveitis. Diagnosis, usually clinically, increased ESR and CRP, positive ANA in oligoarticular, increased ferritin, rheumatoid factors positive in only 15%, and systemic Still's disease, usually associated with a negative RF and ANA. Primarily a clinical diagnosis. In management, NSAIDs, first-line therapy, glucocorticoids if no response to NSAIDs, and physical therapy. Second line or in severe, you can use anakinra, an interleukin-1 receptor inhibitor, also methotrexate and leflunomide. ANA positivity is associated with an increased risk of iridocyclitis, so routine eye exam every 3 months is recommended. And next, just to compare gout and pseudogout. For gout, on arthrocentesis and clinical exam, you may find tophi, which are uric acid depositions. You may find podagra, which is the first metatarsal phalangeal involvement. And for crystals, they'll be needle-shaped, negatively bifringent, and you also find rat bite lesions in chronic. For pseudogout, you'll have that chondrocalcinosis, which is cartilage calcification and deposition in the soft tissue. So maybe in the meniscus on radiograph, you'll be able to see depositions of calcium in that soft tissue. Further comparing it, gout for prevalence is 17 to 20 per 1,000, so very common. Mostly adult men or postmenopausal women. Gout is a monosodium urate crystal, again negatively bifringent with a needle shape, and it's most commonly in the MTP joint, podagra. 50% initially and 90% eventually will deposit there, and 80% are monoarticular, typically in the lower extremity. Radiographically, again, mouse bite or punched out erosions. And therapeutic options for acute attacks of gout are NSAIDs first line, colchicine, and corticosteroids. Chronic management, uric acid lowering agents like allopurinol, the xanthine oxidase inhibitor, febuxostat, and probenecid, which helps excrete excess uric acid. Also colchicine. For pseudogout, it's more rare, under 1 per 1,000 individuals. This is a female predominance, and also the elderly. The crystals are calcium pyrophosphate dihydrate, and they're weakly positive on synovial fluid crystal analysis. They're rhomboid shaped and positively bifringent. Most commonly affects the knees, wrists, MCPs, elbows. And the radiographically, it'll be chondrocalcinosis, which is calcification of the cartilage. And for an acute attack, you want to use steroids first line, as opposed to NSAIDs and colchicine first line for gout. So intra-articular steroid injection for acute attacks of CPPD, and NSAIDs and colchicine second line. Chronic management is NSAIDs plus or minus colchicine. And to note that medications used in the chronic management of gout are not initiated during an acute attack because it may precipitate an attack. Colchicine can be used for acute and chronic. Any acute increase or decrease in serum uric acid levels can cause an acute attack. Note that measuring serum uric acid levels are generally not helpful to determining if the attack is due to gout. Next, to analyze the arthrocentesis, analysis of the fluid. For normal, white blood cells will be 200. Inflammatory arthritis such as gout, it'll be under 50K. Pseudogout under 50K. Reactive arthritis and other inflammatory arthritis under 50K. And if there's septic arthritis, over 50K with over 90% neutrophils. Gout will have negatively shaped crystals, negative bifringents, and uric acid crystals. And again, pseudogout, rhomboid-shaped crystals, positively bifringent, and calcium pyrophosphate crystals. And septic arthritis, bacteria and cloudy, as well as a positive culture. Now to go through some of the high-yield antibodies and autoantibodies and the classic diseases they're associated with. So first, acetylcholine receptor is myasthenia gravis. B2 glycoprotein 1 is antiphospholipid antibody syndrome found in SLE. Cardiolipin antibodies are found in antiphospholipid antibody syndrome in SLE. Centromere antibodies are found in CREST syndrome, the limited systemic sclerosis. CCP proteins, cyclic citrullonated peptide, are specific for RA. So remember, rheumatic factor is used for the screening, but it's not as specific as CCP. dsDNA, or double-stranded DNA, is specific for SLE. Endomysial antibodies are celiac disease. GBM, or glomerular basement membranes, are Goodpasture syndrome. DNA histone is drug-induced lupus. Remember the HIP-Q, hydralazine isoniazid, procainamide, quinidine. Histones for drug-induced lupus. JO1 for poliomyositis and dermatomyositis. LA, also SSB for Sjogren's syndrome. Lupus anticoagulant for antiphospholipid antibody syndrome in SLE. MI, or MI2, dermatomyositis. Mitochondrial antibodies in primary biliary cirrhosis, PBC. MuSK antibodies, muscle-specific receptor tyrosine kinase in myasthenia gravis, may be positive in ACH-negative patients with myasthenia gravis. P-ANCA, microscopic polyangiitis, Churg-Strauss, ulcerative colitis, don't forget, and PSC, primary sclerosing cholangitis. So remember, PBC, primary biliary cirrhosis, is mitochondrial antibodies, but primary sclerosing cholangitis is P-ANCA. Rheumatic factor is rheumatoid arthritis. Ribonucleoprotein is mixed connective tissue disease in SLE. Rho, SSA, is seen in Sjogren's and SLE, so both S's in Rho, SSA. Saccharomyces cerevisiae is Crohn's disease. SCL70 topoisomerase is diffuse systemic sclerosis, scleroderma. SRP, signal recognition protein, is polymyositis. Smith antibodies are systemic lupus erythematosus. Smooth muscle antibodies are autoimmune hepatitis. Thyroglobulin is Hashimoto's thyroiditis, and as well as autoimmune thyroiditis. Thyroid peroxidase, TPO, again Hashimoto's and autoimmune thyroiditis. Transglutaminase, celiac disease, and dermatitis herpetiformis. TSH, thyrotropin receptor, Graves' disease. Voltage-gated calcium channels in Lambert-Eaton syndrome. So next, going to osteoporosis. This is loss of bone density, both mineral and matrix, over time due to imbalance and increased bone reabsorption over formation. Osteopenia is a precursor to osteoporosis. Primarily, it can be postmenopausal and senile. Risk factors are Caucasians, thin body habitus, corticosteroid use, smoking, chronic kidney disease, alcohol, low calcium and vitamin D intake, and physical inactivity and sedentary lifestyle. Secondary causes of osteoporosis are due to chronic disease or medications, like hypogonadism, high cholesterol states like excess glucocorticoid use and Cushing's syndrome, also hyperthyroid states, diabetes mellitus, low estrogen, malignancy, heparin, phenytoin, lithium, and levothyroxine are all secondary causes of osteoporosis. Clinical manifestations, usually asymptomatic. Bone fractures can be manifestation, which may develop pathologic fractures, back pain, or deformity. Pathologic fractures are most common in the vertebrae. Spine compression is possible, with lumbar and thoracic being most common, and this is loss of vertebral height, shortening of stature, kyphosis, hunchbacking, bowing forward curvature of the spine, and back pain. For diagnosis, importantly, is the DEXA scan. which is the dual X-ray exormetry, bone densometry. Best diagnostic test. The normal is 1.0 or greater. The T-score compares bone density with bone density of a younger woman. Osteopenia is a T-score of -1 to -2.5, and osteoporosis is bone density with a T-score of -2.5 or less. Ancillary tests: normal serum calcium, phosphate, PTH, and ALK-Phos, slight elevations of alkaline phosphatase may occur after acute fractures. Decreased vitamin D, screen for thyroid as well as celiac disease. For management, you want to do lifestyle modifications first, which will be vitamin D, ergocalciferol 800 milligrams international units, plus calcium supplementation initial therapy, 1500 milligrams per international unit, and weight-bearing exercise, weightlifting, high-impact resistance training, jogging, jumping, walking, smoking cessation, fall prevention, periodic height, and bone mass measurements. Bisphosphonates are the first-line medical management to prevent osteoporosis. They inhibit osteoclast-mediated bone reabsorption and turnover. Denosumab is an option for initial therapy in patients with a high risk for fracture, intolerant, or unresponsive to other therapies, including IV bisphosphonates. These are our rankle inhibitors, RANKL. There's also teriparatide, which is an anabolic recombinant human PTH analog that is an option for men or postmenopausal women with severe osteoporosis, such as a T-score of under 3.5 or less, even in the absence of fractures, or a T-score of under 2.5 or less, plus a fragility fracture. You can also use raloxifene, which is a SERM, selective estrogen receptor modifier, that inhibits bone reabsorption and reduces the risk of vertebral fractures in postmenopausal women. It has an additional benefit of breast cancer prophylaxis. It may also be used to prevent osteoporosis. Calcitonin can also be used, although this is usually a last-line therapy because of its relatively weak effects on bone density, poor anti-fracture effects, and increased risk of cancer. Screening: DEXA scan in patients 65 years or older, or anyone with a risk equal to that of a 65-year-old Caucasian female. Next, disorders of the back and spine. First, herniated disc, herniated nucleus pulposus. This is most common at the L5-S1 because it is the junction between the mobile and non-mobile spine. Also L4 and L5, but most common L5-S1, as the sacrum is not really mobile. Clinical manifestations: radicular back pain, usually unilateral, may radiate down the leg with paresthesias or numbness in a dermatomal pattern. Pain may increase with coughing, straining, bending, sitting, and Valsalva. Physical examination: positive straight leg raise or crossover test. And to go over the sensory weakness and reflexes that are diminished for L4, L5, and S1, as they are high yield. So for L4, this will be anterior thigh pain, sensory loss to the medial ankle, weakness with ankle dorsiflexion, and reflexes diminished will be loss of knee jerk, weak knee extension with the quads as well. So L4 is really anterior thigh and everything associated with that. L5, you'll have lateral thigh, leg, hip, groin, paresthesias, and pain. It'll affect the dorsum of the foot, especially between the first and second toes, and you'll have weakness with big toe extension, big toe dorsiflexion. Walking on heels is more difficult than walking on toes for these patients, as they're having trouble dorsiflecting. The reflexes that are diminished in an L5 herniated disc are actually normal. They could have some loss of ankle jerk reflex, but usually normal in L5. In S1, this is a posterior leg and calf and gluteus involvement. Plantar surfaces of the foot are involved. Plantar flexion is diminished and weak. Walking on toes is more difficult than on heels. And you have loss of ankle jerk reflex for this S1. So diagnosis of herniated disc, our radiographs will show a loss of disc height, loss of lordosis due to spasm, and degenerative changes. For MRI, this is the diagnostic test of choice for suspected herniation, persistent pain, or refractory pain. For management of herniated disc, conservative is first line, preferred initial management, NSAIDs plus continuation of ordinary activities as tolerated. If bed rest is advised, it should be brief. Physical therapy, muscle relaxers, or oral steroids taper in select patients. So yeah, don't confine them to bed as it'll make it worse. They need to stay mobile. Corticosteroid injection is a second line if refractory to first line therapy, usually performed after MRI confirmation of disc disease. Last line is operative, laminectomy or discectomy if persistent disabling pain over 6 weeks, not responding to non-operative options or evidence of Cauda-Equina syndrome. Next, we'll move into Cauda-Equina syndrome. This is a constellation of symptoms as a result of terminal spinal nerve compression in the lumbosacral region. Massive central herniation compresses several nerve roots of the Cauda-Equina, considered a neurosurgical emergency. Etiologies: lumbar disc herniation is most common, could also be spinal stenosis, trauma, tumors, epidural abscesses, epidural hematoma, and vertebral fractures. Clinical manifestations are back pain plus any one of the following: radiculopathy, bilateral leg radiation of pain, and weakness in multiple roots distributions, such as L3 to all the way to S1. May also be unilateral. They could also, in Cauda-Equina syndrome, involve the S2 to S4 spinal nerve root. This would involve saddle anesthesia, classically, decreased sensation to the buttocks, perineum, and inner surface of the thigh, erectile dysfunction, new onset of urinary or bowel retention or incontinence, and decreased anal sphincter tone on physical exam, decreased anal wink test. And those are specifically all for Cauda-Equina involving the S2 to S4 spinal nerve roots. For diagnosis, MRI is the test of choice, and CT myelogram if unable to perform MRI, such as if they have a metal device like a pacemaker. Management: emergent decompression. It's considered a neurosurgical emergency. Corticosteroids to reduce inflammation. Next will be vertebral compression fracture. These are burst fractures occurring in children from falling and jumping from heights. Pathologic lumbar compression fracture may occur in the elderly, such as with osteoporosis, as well as with malignancy, such as multiple myeloma, prostate cancer, or systemic illness. Clinical manifestations are localized back pain with focal midline tenderness at the level of the fracture. Nerve root deficits may be present in the presence of retropulsed bone fragments in the spinal cord. Diagnosis is by radiograph, loss of vertebral height. MRI or CT not usually necessary, but may provide additional info. Imaging indicated if neurologic deficits are present. Management: orthopedic and neurosurgery consult to determine appropriate workup and management. Conservative: observation, analgesics, bracing, with gradual return to activity. Surgical: kyphoplasty may be used if symptoms are severe or persistent. Lumbar spinal stenosis, also known as pseudocalcification or neurogenic. Narrowing of the spinal canal with impingement of the nerve roots. Etiologies: degenerative arthritis or spondylosis, most common, especially over 60 years old. Post-surgical, congenital, traumatic, and inflammatory as well, but no over 60 years old. Clinical manifestations: back pain, numbness, and paresthesias that may radiate to the buttocks and thighs bilaterally. The symptoms are worsened with extension, prolonged standing, walking upright and walking downhill, and relieved with flexion, sitting, leaning over a shopping cart, walking uphill, and cycling. Unlike claudication, lumbar flexion increases the canal volume. So important maneuvers to know that worse with extension, relieved with flexion, consider stenosis of the spine. Not worsened with Valsalva, as in the case with a herniated disc. Diagnosis: MRI is test of choice. Radiographs: non-specific degenerative changes. Management: conservative, pain control, physical therapy, cycling and swimming. Lumbar corticosteroid injections, epidural or foraminal, may reduce the need for surgical intervention. Surgical management for severe or refractory cases, this would be a decompression laminectomy. Next, lumbosacral strain or sprain. Acute strain or tear of the paraspinal muscles, especially after twisting or lifting injuries. Most common cause of lower back pain. Clinical manifestations: back pain and muscle spasms that is activity related, does not radiate to the leg and is not associated with neurologic symptoms, may develop stiffness and difficulty bending. Physical examination: decreased range of motion, paraspinal muscle tenderness may be present, and no neurological changes. Diagnosis: clinical. Radiographs are not needed unless symptoms are persistent or alarm symptoms are present. Management: analgesics, NSAIDs, and resumption of ordinary activity is preferred. Brief bed rest, maximum of 2 days, may be indicated if moderate pain. And muscle relaxers may help with the spasm in some cases, like cyclobenzaprine. Next, a spinal epidural abscess. This is a pus-filled collection often associated with osteomyelitis and discitis. The abscess can expand, compressing the brain or the spinal cord. Posterior is the most common for these abscesses, and etiologies are Staph aureus most common, 60%. Also gram-negative such as E. coli, and it's possible to have strep, coagulase negative staph, and Mycobacterium tuberculosis in the developing world, which is also known as Pott's disease, TB of the spine. Risk factors: over 50 years old, IV drug abuse, immunodeficiency, such as diabetes, HIV, immunosuppressive medications like corticosteroids, recent spinal procedures, and epidural catheter placement. Clinical manifestations: the classic triad for epidural abscess is fever, plus spinal pain, plus neurologic deficits. Back pain is usually focal and severe, and this is the most common symptom, and they may also have radiculopathy, nerve root pain. Myelopathy, neurologic deficits, motor, sensory, bowel, or bladder dysfunction, paralysis is associated with increased risk of irreversibility. So importantly, immunocompromised patients, IV drug use, fever and spinal pain, and neurologic deficits. To diagnose a spinal epidural abscess, use an MRI with gadolinium, which is the test of choice, will reveal a ring-enhanced lesion. Radiographs are usually normal. CT scan may be used if MRI is contraindicated. Inflammatory markers like ESR, CRP may also have an elevated white blood cell count. Management of spinal epidural abscess: primary goals are elimination or reduction of the inflammatory mass and treatment of the organism. Aspiration, drainage, and antibiotics can be used. Decompression laminectomy and drainage are usually indicated if neurologic deficits, large abscess, or spinal instability. For antibiotics for these patients, you want to do vancomycin to cover the gram-positives, plus either cefotaxime or ceftriaxone for the gram-negatives. You could also use cefepime or ceftazidime if Pseudomonas is suspected, which is a gram-negative. IV corticosteroids may be used in some cases to control the acute neurologic deficits. Conservative, non-surgical management: systemic antibiotics alone may be used in selected patients. No neurologic deficits, patients not a surgical candidate due to medical comorbidities. Next, spinal cord compression. External compression of the spinal cord due to malignancy or infection. This is a neurologic emergency, and clinical manifestations are a sudden onset of focal neurologic deficits at a sensory level, hyperreflexia below the level of compression. Diagnosis by MRI, and management: systemic glucocorticoids for acute neurologic symptoms, and management of the underlying cause. Surgical decompression if not responsive to the initial management. Next, importantly, is scoliosis. This is a lateral curvature of the spine. It may be associated with kyphosis, which is humpback, or lordosis, which is sway back. Most common in girls in positive family history. Adolescent idiopathic scoliosis, AIS, is a Cobb angle over 10 degrees, age of onset over 10 years, and no underlying etiology like neuromuscular or congenital. For screening, you want to do the Adams forward bend test. This is the most sensitive physical finding. Thoracic or lumbar prominence on one side is seen with scoliosis. Scoliometer is also can be done with screening. This is a 7-degree curve is considered abnormal. So over 7 degrees of curve is considered abnormal with a scoliometer. Also the forward bending sitting test and assessments including leg length, waistline asymmetry, midline skin defects, cafe au lait spots, foot deformities, and abdominal reflex asymmetry. For confirmation, you want to get a radiograph that'll show a Cobb's ankle of greater than or equal to 10 degrees as measured on AP or lateral films. An MRI, not part of the initial evaluation without red flags or abnormal curve types. MRI may be indicated if a rapid curve progression is suspected, left thoracic curve, abnormal reflexes, excessive kyphosis, or foot abnormalities. For management of scoliosis, it's based on the skeletal maturity of the patient and the severity of the deformity and the curve progression speed. So you'll just observe them if the Cobb angle is under 25 degrees and a Reiser score of 0 to 2 at the time of presentation. Regular follow-up to monitor progression every 6 to 9 months. Bracing may be recommended if Cobb angle increases 5 degrees or more over a 3 to 6 month period. Bracing may be needed to stop progression in patients with flexible deformity and still skeletally immature. So you do bracing if 1, if the Cobb angle increases by 5 degrees or more over a 3 to 6 month period, or 2, if the patient's Cobb angle is 30 to 39 degrees. Bracing is contraindicated, however, if they're skeletally mature, little growth remaining, and a Cobb angle greater than or equal to 50 degrees or less than 20 degrees, bracing is contraindicated. Surgical correction may be an alternative to bracing if over 40 degrees and a Reiser score of 0 to 2, which means skeletally immature. So skeletal maturity, the Reiser score is an indication on the iliac crest, which shows you how mature the actual bones are. So 0 will be very immature and 5 will be mature. Thoracic outlet syndrome is next. This is idiopathic compression of the brachial plexus, which is most common. Also could be the subclavian vein or subclavian artery as they exit the narrowed space between the shoulder girdle and first rib. Most common in women 20 to 50 years old. And you want to think, does this patient have an extra rib actually? Clinical manifestations, nerve compression, ulnar neuropathy, pain or paresthesias in the forearm and arm, vascular compression, swelling or discoloration of the arm, especially with abduction of the arm, erythema, edema, or cyanosis of the affected arm. On physical exam, they'll have a positive Addison sign, which is a loss of radial pulse with head rotated to the affected side, confirmed with MRI. Management, controversial. Physical therapy is first line, avoid strenuous activity, orthopedic consult, and surgery. Next, spondylolysis. This is a pars interarticularis defect due to failure of fusion or stress fracture, most common at L5-S1, remember because of the mobility of this joint between the immobile sacrum and the mobile lumbar spine. Mechanism, often from repetitive hyperextension trauma, like football players, gymnasts, weightlifters. Often the first step in spondylolisthesis, forward slipping of a vertebrae on another. Clinical manifestations of spondylolysis, most cases are asymptomatic, low back pain with activity. Most common form of back pain in children and adolescents. May develop hamstring tightness and sciatica. Diagnosis, lateral radiographs, you'll see a radiolucent defect in the pars. And on oblique radiographs, the normal appearance of the lumbar spine has been described to resemble a Scotty dog. So this is important, Scotty dog on oblique radiographs. If spondylolysis is present, the pars interarticularis, which is the neck of the Scotty dog, will have a defect or break, looks like the collar around the neck. Again, you can also do a CT or a bone scan. Management of spondylolysis, low grade or asymptomatic, you can observe with no activity limitation or asymptomatic and low grade. If they are symptomatic, physical therapy and activity restriction in some patients. Lastly, bracing may be helpful for acute pars stress reaction or if failed physical therapy, but not typically. Next, spondylolisthesis, a forward slipping of a vertebrae on another, bilateral fracture or defect of the pars interarticularis. Mechanism, usually a complication of spondylolysis. Clinical manifestations, most cases are asymptomatic. Low back pain is the most common symptom. Nerve compression, sciatica, bowel or bladder dysfunction, and neurologic deficits if severe. Diagnosis by radiographs, forward slipping of a vertebrae. Lateral views used to measure the slip angle and grade it. Flexion and extension views can help to evaluate stability. An MRI is indicated if neurologic symptoms are present from the spondylolisthesis and present to assess stenosis or complications. Management, mild, treat like spondylolysis, physical therapy and activity restriction in some symptomatic patients. Severe, cases may need surgical intervention. So just a note on how they're graded. They're graded on a scale of 1 to 4. So a 1 is between 0 and 25% displacement. A 2 is between 25 to 50% displacement. A grade 3 is between 50 and 75% displacement. And 4 is 75 to 100% displacement in spondylolisthesis. Next, we'll move to upper extremity, and we'll start with shoulder injuries. So first is an anterior glenohumeral dislocation, so a shoulder dislocation. The mechanism, most common after a blow to an abducted, externally rotated, and extended extremity. Also a fall to the outstretched hand or posterior humeral force. So think about like a quarterback reaching back to throw and then getting hit in that way and further hyperextending there. Anterior is the most common type of shoulder dislocation. Physical examination. Arm held in abduction and external rotation, the elbow pointing out. The humeral head is often palpable inferiorly with loss of deltoid contour or a squared off shoulder. Diagnosis, shoulder radiographs. Usually the initial test of choice. Axillary and scapular Y views most helpful in distinguishing anterior from posterior. You can also have a Hill-Sachs lesion, which is a groove fracture of the humerus itself, and a Bankart lesion, which is a glenoid rim fracture. And both these can occur as the shoulder dislocates and damages the surrounding structures. So remember, Hill-Sachs is on the humerus, and Bankart is a glenoid rim fracture. You can also do CT and MRI to give more details about soft tissue. Management, reduction and immobilization. Check deltoid pinprick sensation for axillary nerve involvement, pre- and post-reduction. Physical therapy. And complications include injuries to the axillary nerve, most commonly, axillary artery, brachial plexus, suprascapular nerve, and radial nerve. Neurovascular examination done pre- and post-reduction. So important. Axillary nerve, check deltoid pinprick sensation, and know your Hill-Sachs, Bankart lesions, and Y view. Posterior glenohumeral shoulder dislocation. Mechanism, forced adduction, internal rotation. So posterior glenohumeral shoulder dislocation is most commonly associated with seizures, electric shock, or trauma. Physical examination, the arm is adducted and internally rotated. The anterior shoulder appears flat with a prominent humeral head. On diagnosis, radiographs should be obtained initially, again using the scapular Y view and axillary lateral views to best distinguish anterior versus posterior. AP films may show a light bulb sign. The appearance of the humeral head looks like a light bulb or ice cream cone. And CT and MRI can be used to assess for further complications. Management is to reduce and immobilize. Also, neurovascular compromise is uncommon with this one. Glenolateral or capsular injuries may lead to posterior shoulder instability. Okay. Next, moving to AC joint dislocation, acromioclavicular joint dislocation, also known as shoulder separation. The mechanism is a direct blow to an adducted shoulder. Physiology: the acromioclavicular ligament provides horizontal stabilization. The corcoclavicular ligament provides vertical stabilization. So we'll take a look at a picture in the anatomy of this. Clinical manifestations: pain with lifting the arm, unable to lift the arm at the shoulder. There may be deformity or a step off at the AC joint. So this is important to differentiate between the squared off shoulder of the anterior shoulder dislocation and the step off of the AC joint deformity. Diagnosis: radiographs taken without weights or with weights to reveal mild separations. Both shoulders may be visualized to compare the separation. For management, non-operative management is most common in types 1, types 2, and most of types 3. Conservative management includes ice, brief sling and immobilization, and rest. Early rehab for range of motion preservation. Surgical, type 4 and above with under 2 centimeter clavicular displacement, and some patients with type 3, athletes, cosmic concerns. So again, shoulder separation, different types. Type 1 is a normal chest x-ray with ligamental sprain. Type 2 is slightly widening of the joints. So you'll have AC joint rupture, but corcoclavicular joint sprained. Class 3, even more significant widening with rupture of the AC and the CC ligaments. Class 4, again, rupture of the AC and CC ligaments and displacement of the clavicle into the trapezius. And class 5 is a class 4 plus disruption of the clavicular attachments. Next will be rotator cuff injuries. Mechanism: chronic erosion or trauma, impingement of the supraspinatus tendon. Common in athletes and laborers performing repetitive overhead movements, older age, and smoking. The sits muscles are involved: supraspinatus, infraspinatus, teres minor, and subscapularis. The supraspinatus is the most commonly injured muscle. Tendinitis is inflammation, usually associated with subacromial bursitis, most common in adolescents and under 40 years old. Rotator cuff tear, most common cause of shoulder pain over 40 years old. Trauma is 50% or chronic overuse. For clinical manifestations of rotator cuff injuries: anterolateral shoulder deltoid pain with decreased range of motion. Decreased range of motion, especially with overhead activities, external rotation, or abduction, combing hair, reaching for wallet, inability to sleep on the affected side, especially with tears. And you must know, pain at night is very classic for rotator cuff injuries. Passive range of motion greater than active, and also weakness, atrophy, and continuous pain commonly seen with tears. Physical exam: supraspinatus strength test. The empty can test has a 90% specificity for assessing supraspinatus involvement. And you want to do this in the plane of the scapula, so 30 degrees. Impingement tests: positive Hawkins test, drop arm test, and near test. Hawkins test: elbow and shoulder flexed at 90 degrees with sharp anterior shoulder pain with internal rotation. Also the drop arm test: pain with inability to lift the arm above the shoulder level or hold it, or severe pain when slightly lowering the arm after the shoulder is abducted to 90 degrees. Also, the positive near test is the arm fully pronated, thumbs down, with pain during forward flexion, while shoulder is held down to prevent shrugging. Supraspinatus test: pain with abduction against resistance. And also there's the subacromial lidocaine test, may help to distinguish tendinopathy from tears. Normal strength with pain relief equals a tendinopathy. Persistent weakness, classically seen with larger tears. Management of these tears: conservative is first, physical therapy or rehab, and NSAIDs for pain management. Intra-articular corticosteroids, usually reserved for patients who fail NSAID management of pain. Surgery, patients who fail conservative management within 6 months, or patients with complete tears. So management of the tendinitis of the rotator cuff. Shoulder pendulum or wall climbing exercises should be done. Ice, NSAIDs, and stopping the offending activity. Next, proximal humerus and humeral head fractures. Mechanism is often fall in the outstretched hand, direct blow, common site for pathologic fractures as well, in metastatic breast disease. That's very important. Physical examination, arm held in the adducted position, decreased range of motion, pain, swelling, and ecchymosis. Diagnosis, shoulder radiographs usually the initial test, and CT scan may be used to further evaluate, such as pre-op planning and MRI. Management, sling immobilization, analgesics, and physical therapy for rehab in most fractures, surgical for some. Humeral shaft fractures. Mechanism, fall in the outstretched hand and direct trauma. Physical examination, pain and swelling to the arm, ecchymosis, and decreased range of motion. Must rule out a radial nerve injury in this humeral shaft fracture. Management, non-operative coaptation splint or sling and swath with prompt orthopedic follow-up. Operative, open reduction internal fixation for open fractures, vascular or brachial plexus injuries with pain and weakness. Proximal humeral fracture, arm usually adducted, check the deltoid sensation as well as brachial plexus injury, plus or minus crepitus and ecchymosis. If you have a humeral shaft fracture, as opposed to proximal, the mechanism of action is often a Fuchs injury, fall in the outstretched hand, or direct trauma. You have to rule out radial nerve injury and may develop a wrist drop. Next, adhesive capsulitis, or frozen shoulder. This is shoulder stiffness due to inflammation, especially with diabetes and hypothyroidism, also known as frozen shoulder, most common in 40s to 60s. Clinical manifestations, shoulder pain and stiffness with decreased range of motion, especially with external rotation. Stiff pain cycle, and pain is usually worse at night. Associated with gradual return to range of motion, may last 18 to 24 months. On physical examination, resistance on passive range of motion only on the affected side, and management is rehab range of motion therapy is the mainstay, and anti-inflammatories, intra-articular steroid injections, and heat may be helpful. Clavicular fractures, most commonly fractured bone in children, adolescents, and newborns during birth from shoulder dystocia. Most commonly seen in males. The classification is Group 1, which is a mid-shaft fracture, which is the most common, and it's in the middle 1/3. A Group 2 is a lateral or distal third, and a Group 3 is a proximal or medial third. So mid-high energy impact to the area or fall in the outstretched hand. If no history of trauma, think malignancies, rickets, or child abuse, especially if the child is under 2 years of age. On physical exam, pain with range of motion, deformity at the site, may have a tenting of the skin, which is an impending open fracture, and crepitus. May hold the arm against the chest to protect against motion. Management, mid 1/3, is non-operative, sling immobilization in most adults, sling or figure of 8 splint in children. For operative management, indicated for open fractures, displaced fractures with the skin tenting, subclavian artery or vein injuries, severe displacement or shortening. And if it's in the proximal 1/3, orthopedic consult. And often in the proximal 1/3, it's very hard to fracture this area, so you need some high impact trauma or great forces to do so. Complications, pneumothorax, as you're near the apices there, hemothorax, corticoclavicular ligament disruption, distally, and brachial plexus injuries. Next, elbow and forearm injuries. Supracondylar humerus fractures. Mechanism, fall in the outstretched hand with hyperextended elbow. Most common in children 5 to 10 years old. And clinical manifestations, swelling and tenderness at the elbow with decreased range of motion. Diagnosis, displaced. Abnormal anterior humeral line may be seen on lateral radiographs. Non-displaced, displaced anterior fat pad sign or posterior fat pad sign, hemarthrosis, is suggestive of fracture. Very important. Complications of supracondylar humeral fractures. Median nerve and brachial artery injury may lead to a Volkmann ischemic contracture, which is a claw-like deformity from ischemia with flexion and contracture of the wrist. They may have radial nerve injury as well. Management, non-displaced, long arm posterior splint followed by long arm casting. If it's displaced, closed reduction and pinning. All displaced fractures or severe swelling should be omitted for observation. Immediate orthopedic consult. So again, you can keep the elbow at 90 degrees and measure the anterior humeral line. Take a look at the coronoid process, the capitellum, and the radiocapitellar line, which should be perpendicular to the anterior humeral line. Also take a look at the radial head and the olecranon process. Supracondylar fractures, you're going to see abnormal anterior humeral line on the lateral view, and also that fat pad sign. So again, supracondylar fracture, we see sometimes there is a normal anterior humeral line, and the only clue is an abnormal or positive posterior fat pad joint effusion. Posterior fat pads are always abnormal. Anterior fat pads may be seen as a normal variant if they are small and mostly parallel to the humerus. Anterior and posterior fat pad equals supracondylar fracture in children equals radial head fracture in adults. Next, radial head fractures. The mechanism is again fall in the outstretched hand, usually intra-articular, involving the joint. Physical examination, lateral, radial elbow pain, inability to fully extend the elbow. Notoriously difficult to see. Positive posterior or displaced anterior fat pad, hemarthrosis, may be the only radiologic evidence of occult fractures. Management, non-displaced, immobilization, such as a sling or long arm splint at 90 degrees, with early range of motion. Displaced, surgical, open reduction, and internal fixation. And remember, for this, it's the Mason criteria that you can follow for radial head fractures in management. Next, suppurative flexor tenosynovitis. Infection of the flexor tendon synovial sheath of the finger. Staph aureus is the most common, Staph epidermidis, group A strep, and Pseudomonas or mixed flora, but mostly Staph aureus. The mechanism is often due to penetrating trauma or contiguous spread from adjacent tissues. Clinical manifestations, pain and swelling, especially to the palmar aspect of the affected finger. Canavel's signs, there's 4 of them, with the mnemonic flex, F-L-E-X, flexor tenosynovitis. So F, finger held in flexion. L, length of the tendon sheath is tender, tenderness along the tendon sheath. Enlarged finger, fusiform swelling of the finger. And X, extension of the finger causes pain, with passive extension. For diagnosis, must differentiate from a Dupuytren's contracture, and radiographs and MRIs are often obtained, but definitive diagnosis is via aspiration or biopsy. Management, incision and drainage with irrigation of the tendon sheath, debridement, and IV antibiotics. Next, olecranon fractures. The mechanism is usually a direct blow or a fall on the flexed elbow. For clinical manifestations, pain, swelling, inability to fully extend the elbow. Complications, ulnar neuropathy, post-traumatic arthritis, anterior interosseous nerve injury, and loss of extension strength. For management, non-displaced, you should do reduction in posterior arm splint in 90 degrees of flexion. All are considered intra-articular and need reduction. If it's displaced, you need to do open reduction internal fixation. Next, olecranon bursitis. This is a direct trauma, repetitive microtrauma or pressure due to gout or inflammation. Could also be septic and infectious, also known as septic bursitis, can occur after penetrating injury or breaking of the skin. Staph aureus is the most common organism. Clinical manifestations, a goose egg or boggy swelling of the posterior olecranon process area. I've also seen it called a student's elbow. Repetitive trauma or chronic, usually painless or minimally tender, often associated with full range of motion or mild discomfort with full flexion. Inflammatory or infectious, may have erythema, warmth, tenderness, with painful, limited range of motion. Evaluate for skin breaks or overlying cellulitis if suspected septic bursitis. For diagnosis, clinical diagnosis in most patients, aspiration of the bursa usually reserved for a suspected septic bursitis or if gout is the suspected cause. White blood cell count under 500 usually indicates non-infectious, non-crystalline bursitis. White blood cell count over 2,000 is often septic. For management, if it's olecranon bursitis, avoid further trauma, padding to the area, NSAIDs if painful and inflammatory, and ACE wrap for compression. You don't necessarily drain it even if it is just olecranon bursitis because the fluid will reaccumulate. Septic bursitis, drainage of the infected bursal, fluid, and antibiotic therapy, like oral dicloxacillin or clindamycin to cover Staph aureus. Next, ulnar shaft, or nightstick fractures. The mechanism is a direct blow, may present with localized swelling and pain. The nightstick fracture is a fracture of the middle portion of the ulnar shaft without any associated fractures. Management of non-displaced distal third, short arm cast, non-displaced mid-proximal third, long arm cast, displaced over 50%, open reduction and internal fixation. Montasia fracture. This is a fracture to the proximal 1/3 of the ulnar shaft plus radial head dislocation. Mechanism is a direct blow to the forearm. How I remember this is M equals FU DR. So montasia equals fracture of the ulnar and dislocation of the radius. Clinical manifestations, elbow pain and swelling, and thumb paresthesias. Radial nerve injury, 17%, due to radial head dislocation, may develop a wrist drop. Management, unstable fractures require ORIF. Next, the Galeazzi fracture. The mid-distal radial fracture of the shaft with dislocation of the distal radial ulnar joint. Mechanism is Fuchs injury again, or direct blow. Clinical manifestations, fracture and deformity of the radial side of the wrist. Additionally, the ulnar head will appear prominent at the wrist because it is dorsally displaced. Management, adults need open reduction internal fixation. It is an unstable fracture. Long arm and sugar tongue splint temporarily. Complications, anterior interosseous nerve injury, loss in pinch between the thumb and index finger. Also possible to have compartment syndrome from this. So one more time, just to differentiate between montasia and Galeazzi. Montasia is a fracture of the ulna and a dislocation of the radius, whereas Galeazzi is a fracture of the radius and a dislocation of the ulnar, and that's distally of the ulnar. Next, radial head subluxation. Nursemaid's elbow. This is a radial head that is wedged into the stretched annular ligament, most common in children 2 to 5 years of age. The mechanism is lifting, swinging, or pulling a child, longitudinal traction, while the forearm is pronated and extended. Physical examination, arm is slightly flexed and child refuses to use the arm, usually no swelling. Tenderness to palpation of the radial head, which will be the lateral elbow. Diagnosis is clinical. You don't usually need a radiograph. Management, you want to do closed reduction. Place pressure on the radial head with supination of the elbow, followed by flexion of the elbow. Observe the child for normal function. If the child uses the arm after 15 minutes, no radiographs are needed. If no use after 15 minutes, consider radiographs to rule out a fracture or reattempt the reduction. Lateral epicondylitis, or tennis elbow. This is inflammation of the tendon insertion of the extensor carpi radialis brevis muscle due to repetitive pronation of the forearm and excessive wrist extension. Clinical manifestations, lateral elbow pain, especially with gripping, forearm pronation, and wrist extension against resistance. May radiate down the forearm or worsen when lifting objects with the forearm prone. This is a Cozen test. So you allow the arm to be parallel to the ground, relax it, and then extend against resistance at the wrist using the radial nerve. Management, conservative, activity modification, rest, ice and NSAIDs, physiotherapy, counterbalance braces, steroid injections may provide short-term benefit, surgery if refractory to conservative management. Next, it's contrary medial epicondylitis, golfer's elbow. Not as common as lateral epicondylitis, and this is common in 40 to 60-year-olds. Mechanism is inflammation of the pronator teres flexor carpi radialis muscles due to repetitive overuse and stress at the tendon insertion of the flexor forearm muscles. Most common in golfers and patients who do household chores. For clinical manifestations, tenderness over the medial epicondyle, worse with pulling activities. For physical examination, pain reproduced by performing wrist flexion against resistance with the elbow fully extended. For management, similar to lateral epicondylitis, however it's more difficult to treat. You want to do activity modification again, RICE, NSAIDs, physiotherapy, counterbalance, intra-articular steroid injections, and again surgery if refractory to conservative management. Next, elbow dislocation. Elbow dislocation, the mechanism is fall on the outstretched hand with hyperextension, high energy, and axial loading. The posterior is the most common. On physical exam, it'll be a flexed elbow, marked olecranon prominence, and inability to extend the elbow, often associated with radial head or coronoid process fracture. Management, stable, emergent reduction with posterior splint at 90 degrees with orthopedic follow-up. Unstable, ORIF. Complications, you must rule out a brachial artery, median, ulnar, or radial nerve injuries as well. Loss of terminal extension is the most common sequel. Joint stiffness and contractures if the splint is left on over 3 weeks. Compartment syndrome as well. Cubital tunnel syndrome, also known as ulnar neuropathy. This is ulnar nerve compression at the cubital tunnel along the medial elbow. Clinical manifestations, paresthesias and pain along the ulnar nerve distribution, worse with elbow flexion. Positive Tenniel sign at the elbow, positive Froment sign, which is ulnar nerve evaluation via adductor polysis. Holding paper and compensates with flexion of the interphalangeal joint. It's the pinching effect. Decreased sensation to the fifth and ulnar side of the fourth finger. I'll add a picture of this Froment sign. Management, wrist immobilization, especially with sleep and NSAIDs. Also intra-articular steroids if chronic. Next we'll move to wrist injuries. So first, the scaphoid or navicular fracture. Mechanism is fall in the outstretched hand. Most common fracture of the carpal bone. 85% occur at the waist. At the wrist, it must mean. Clinical manifestations, pain along the radial surface of the wrist with anatomical snuffbox tenderness. That's classic, anatomical snuffbox tenderness. Radiographs, the fracture may not be evident for up to 2 weeks, importantly. If the snuffbox tenderness is present, treat as a fracture because of the high incidence of avascular necrosis or non-union, since the blood supply to the scaphoid is distal to proximal as opposed to normally proximal to distal. Management, non-displaced fracture or snuffbox tenderness. Do a thumb spica splint. If it's displaced over 1 millimeter, open reduction and internal fixation with percutaneous pin placement. Next, scapholunate dissociation, widening space between the scaphoid and lunate bones. Mechanisms, fall in the outstretched hand. Clinical manifestations, pain on the dorsal radial side of the wrist with minimal swelling. Pain is increased with dorsiflexion. May have a click or wrist movement. Diagnosis: widening scapholunate space over 3 millimeters. This is called a Terry-Thomas sign. So scapholunate joint dissociation over 3 millimeters is a Terry-Thomas sign. Management: initially radial gutter splint, surgical repair of the scapholunate ligament usually required to prevent slack of the wrist. Osteogenesis imperfecta is next. This is an autosomal dominant disease leading to defects in the gene that encodes for type 1 collagen. And you can remember bone type 1, ONE. Associated with fetal or perinatal death and intrauterine growth retardation in its most severe form. Clinical manifestations: severe premature osteoporosis, multiple recurrent spontaneous fractures with minimal or no trauma in childhood leading to limb deformities and shortening. Pre-senile deafness. So this is due to lack of the osteogenesis of the auditory ossicles, which are really small bones. Physical examination, you see the blue tinted sclera, which is hallmark, and brown teeth as well. For diagnosis, it's clinical and radiologic findings, confirmed with DNA or protein testing. And for management, combination of bisphosphonates, physical therapy, and surgical interventions. Next will be the Colles fracture. This is a distal radius fracture with dorsal angulation. The ulnar styloid fracture is also seen in 60%. The mechanism is fall in the outstretched hand with wrist extension, importantly. Clinical manifestations of the Colles fracture: wrist pain worse with passive motion. On physical exam, a dinner fork deformity appearance to the wrist. Radiographs will show a lateral view with dorsally displaced or angulated extra-articular fracture of the distal radius. Lateral view may be needed to distinguish Colles versus a Smith fracture, since one is a dinner fork and one is a garden spade deformity. Management of the Colles fracture: closed reduction followed by a sugar tongue splint or cast is the initial management. Open reduction internal fixation if comminuted or unstable, over 20 degrees angulation, intra-articular, or over 1 centimeter shortening. Complications: the extensor pollicis longus tendon rupture is most common. So extensor pollicis longus tendon rupture. Also malunion and non-union, joint stiffness, median nerve compression, residual radial shortening, and complex regional pain syndrome, CRPS. Next, its opposite, the Smith fracture. The Smith fracture is an extra-articular distal radius fracture with ventral angulation of the distal fragment. Mechanism, again, fall in the outstretched hand, except this time the Smith fracture has fall in the outstretched hand with wrist flexed as opposed to extended with the Colles fracture. Smith fracture will be pain with passive motion and a garden spade deformity of the wrist. Diagnosis: radiographs, lateral view will show a ventrally displaced or angulated extra-articular fracture of the distal radius. The lateral view may be needed to distinguish Colles versus Smith. Management: closed reduction followed by a sugar tongue splint is the initial management. Open reduction with internal fixation if comminuted or unstable. So remember, Colles is dorsal angulation, Smith's is ventral angulation, and also know there's a Barton fracture, which is an intra-articular distal radius fracture with carpal displacement. So that's that distal radial styloid fracture on the edge there. That's a Barton fracture. Next will be lunate dislocation. The lunate does not articulate with both the capitate and the radius. The mechanism is often high energy injuries while the wrist is extended and ulnarly deviated. Clinical manifestations: acute wrist swelling and pain, may develop median nerve symptoms. Diagnosis of lunate dislocation: on the AP, you'll see lunate appears triangular piece of pie sign. On lateral view, there'll be volar displacement with a tilt of the lunate showing a spilled teacup sign. So remember the different nerves of the arm and what tests can be done. So for the radial nerve, you'll see wrist drop, and you want to do the Cozen test to test the radial nerve in wrist extension. For the medium nerve, you want to do pinky to thumb or an OK sign and have them hold that and try to basically break it open, testing both hands to see the difference. And ulnar nerve, You can spread and push laterally. Ask them to spread their fingers and push laterally from many different angles. For management of the lunate dislocation, you can do emergent closed reduction and splint, followed by open reduction and internal fixation. This is also an orthopedic emergency. So remember, spilled teacup sign and piece of pie sign is lunate dislocation. Perilunate versus lunate dislocation is an important distinction. The perilunate dislocation is the lunate does not articulate with the capitate, but still articulates with the radius. And for lunate, the lunate doesn't articulate with the capitate or the radius. And this is the spilled teacup sign on the lateral view. So for perilunate, the rest of the hand is off distally. So it's really the hand that's been moved, and the lunate's just staying on the radius. As opposed to the lunate dislocation, only the lunate is dislocated. Next, lunate fracture itself. This is the most serious carpal fracture, since the lunate occupies 2/3 of the radial articular surface. Radiographs are often negative. Complications: avascular necrosis of the lunate bone. This is known as Kienbock's disease. Again, Kienbock's disease, avascular necrosis of the lunate bone following a lunate fracture. And you need to immobilize and have orthopedic follow-up. Next, CRPS, or complex regional pain syndrome, formerly known as reflex sympathetic dystrophy, RSD. This is an autonomic dysfunction following bone or soft tissue injuries, such as a wrist fracture or post-surgery, and 30% have no history of injury. Most commonly affects the upper extremities and women that are over 30. Characterized by 4 main symptoms after the initiating event. First, sensory. They'll have pain, hyperalgesia, often out of proportion to the initial injury. Motor and trophic changes, such as decreased range of motion and motor dysfunction with trophic changes, increased hair and nail growth initially, followed by decreased growth. Edema or swelling. And V for vasomotor, temperature and skin color asymmetry with autonomic dysfunction. So SMEV, sensory, motor, edema, and vasomotor, with that temperature and skin discoloration due to autonomic dysfunction. Diagnosis is mainly a clinical diagnosis, although radiographs may show a patchy osteoporosis. Bone scintigraphy may show increased uptake or activity. Diagnostic criteria, typically an initiating event or immobilization, persistent pain, allodynia, or hyperalgesia out of proportion to the initiating event. Symptoms of edema, changes in skin blood flow, or abnormal pseudomotor activity. No other obvious diagnosis that could explain the symptoms. It's a diagnosis of exclusion. For management, NSAIDs is the initial treatment, physical and occupational therapy, anesthetic blocks, oral corticosteroids, TCAs, and transcutaneous electrical nerve stimulation, TENS machines. Also importantly, this is often tested, vitamin C prophylaxis after fractures may reduce the incidence of CRPS. Vitamin C prophylaxis after fractures for CRPS. Next, de Quervain's tenosynovitis or tendinopathy. This is stenosing inflammation of the tendons, the entrapment tendinitis, of the first dorsal compartment, the APL, and the EBP, the abductor pollicis longus and extensor pollicis brevis. That's important. And mechanism, excessive thumb use with repetitive action, such as thumb abduction and extension, seen in golfers, clerical workers, women that are postpartum, importantly, from lifting the newborn, also diabetics. Clinical manifestations, pain along the radial aspect of the wrist and base of the thumb, radiating to the forearm, especially with thumb extension or gripping. Pain and tenderness at the radial styloid. Swelling and thickness over the tendon sheath may be present. And we just said, remember, Barton's fracture is the radial styloid fracture. So diagnosis of de Quervain's tenosynovitis is a Finkelstein test. Finkelstein test, positivity equals first dorsal compartment pain with ulnar deviation while the thumb is flexed in the palm, or pain with thumb extension. So you're basically making a fist except the thumb is inside and then you're ulnarly deviating, and that will cause pain. Management, thumb spica-splint is the initial management, NSAIDs and physical therapy. Corticosteroid injection may be used if initial treatment is unsuccessful. Surgical release usually reserved for refractory cases to non-operative management. Next, the mallet or baseball finger. The mechanism of this is an avulsion of the extensor tendon after a sudden blow to the tip of the finger causing forced flexion of the extended finger. Physical exam, unable to actively extend the DIP joint. Radiographs, normal or avulsion fracture of the distal phalanx at the tendon insertion site. Management, non-operative, uninterrupted extension splint of the DIP for 6 to 8 weeks. And remember, this must be uninterrupted extension, or else they risk having it fall into flexion and it never repairing at all. Also for management, closed reduction and percutaneous pinning if displaced mallet finger with subluxation, and operative or RIF if the closed reduction and percutaneous pinning cannot be done, or tendon reconstruction. But first line for mallet finger is that non-operative uninterrupted extension of the DIP for 6 to 8 weeks. Next, the boutonniere deformity. The mechanism is a sharp force against the tip of a partially extended digit, leading to hyperflexion at the PIP joint with hyperextension at the DIP. So it looks like an actual boot for boutonniere. Disruption of extensor tendon at the base of the middle phalanx. Management is a splint PIP in extension for 4 to 6 weeks with a hand surgery follow-up. So remember, mallet finger is the finger flexed at the DIP and unable to extend at the DIP. Boutonniere is flexed at the PIP and hyperextended at the DIP. And swan neck deformity is finger hyperextended at the PIP and flexed at the DIP. Next, gamekeeper's or skier's thumb. This is a sprain or tear of the ulnar collateral ligament of the thumb, leading to instability of the MCP joint, metacarpal phalangeal. Skier's thumb is an acute condition after a fall, and gamekeeper's is typically a chronic hyperabduction injury. Mechanism, forced abduction of the thumb. Ulnar collateral ligament functions to resist against valgus force. Clinical manifestations, the thumb far away from other digits, especially with a valgus stress, pulling the thumb away from the hand. MCP tenderness, weakness in pinch strength. Plus or minus a fracture at the base of the proximal phalanx. If the ulnar collateral ligament ruptures, it may pull off a piece of bone in avulsion. Management, thumb spica splint and referral to hand surgery because it affects the pincer function. Complete rupture, surgical repair. Next, a boxer's fracture. This is a fracture through the 5th metacarpal neck, maybe the 4th as well. Mechanism, direct trauma to a closed fist against a hard surface, as if punching a wall or somebody else. Clinical manifestations, pain along the dorsum of the 5th metacarpal of the hand with swelling, ecchymosis, and may have loss of the appearance of the 5th knuckle if angulated. It may have rotational deformity. And remember, rotational deformity is very important for this injury. Diagnosis is by radiographs. In management, initially, you want to do an ulnar gutter splint with joints in at least 60 degrees of flexion. Reduction requiring prior to the splinting of any fracture that's over 25 to 30 degrees of angulation. So knowing if there's angulation or not is important as you're going to do reduction before the splinting. Open reduction with internal fixation if the 5th digit remains over 40 degrees angulated, or 30 degrees for the ring finger. And always check for bite wounds, especially humans. In present, treat with the appropriate antibiotics like augmentin, especially amoxicillin clavulanate. Okay, so you want to reduce if it's over 25, and ORIF if the 5th digit is over 40%, 40 degrees rather, angulated. Next, a Bennett's fracture, or a dislocation and Rolando fracture. So we'll differentiate between them. Metacarpal fractures involving the base of the thumb. Mechanism is an axial force applied to the thumb in flexion. A Bennett fracture is a non-comminuted partial intra-articular fracture, whereas a Rolando fracture is a comminuted complete intra-articular fracture. Clinical manifestations, pain, swelling, ecchymosis, and tenderness to the CMC, carpal metacarpal joint of the thumb. Diagnosis, on radiograph you'll see a Bennett fracture which will be a small fragment of the first metacarpal base articulating with the trapezium. A Rolando fracture, you'll have the Y sign for Rolando, splitting of the first metacarpal base into dorsal and volar fragments. Management: immediate thumb spicosplint for temporary stabilization. For Bennett, you want to do immobilization, closed reduction with percutaneous pinning, ORIF if large fragment, and joint displacement. For Rolando, remember the Y sign, unstable often needs ORIF, external fixation or closed reduction and percutaneous pinning. So remember, one more time, Bennett's fracture, intra-articular fracture through the base of the first metacarpal. Rolando is a comminuted Bennett's fracture with that Y sign, so it's broken in two places. Next, pronator teres syndrome. Pronator teres syndrome is proximal forearm median nerve compression, where the nerve traverses the pronator teres muscle, usually due to entrapment of the median nerve between two heads of the pronator teres muscle. Clinical manifestations: paresthesias or pain of the lateral palmar aspect of the first three and the radial half of the fourth digits. May have sensory loss over the thenar eminence. Symptoms are not worse at night compared to carpal tunnel syndrome, helps differentiate it, and tenderness over the proximal median nerve aggravated by pronation of the arm. So you can have the patient give you a handshake and then ask them to rotate in, and that will cause them pain. Management: initial management is reduction in the symptoms inducing activities and NSAIDs for pain. You can do steroid injections if no relief, and surgical decompression in refractory cases of pronator teres syndrome. Next, carpal tunnel syndrome in contrast. It's also median nerve involvement, except this is median nerve entrapment and compression at the carpal tunnel itself. Increased incidence in women, diabetics, pregnancy, hypothyroidism, rheumatoid arthritis, and occupations with repetitive extension and flexion, such as typing. Clinical manifestations: paresthesias and pain of the palmar aspect of the first three and radial half of the fourth digits, especially at night. Very important, especially at night for carpal tunnel. Also some clumsiness and weakness, and you may see thenar muscle wasting in advanced cases. So remember, thenar versus hypothenar. Diagnosis: workup may include EMG and nerve conduction velocity studies. Especially important to know the Tenniel sign, positive if percussion of the median nerve produces symptoms, and the Phelan sign, positive if flexion of both wrists for 30 to 60 seconds reproduces the symptoms. For management of carpal tunnel, you want to do conservative first, with a volar splint as the initial management, NSAIDs, avoiding repetitive wrist movements, corticosteroids injection, and carpal tunnel surgery if refractive or severe cases. So differentiating from pronator teres syndrome, the median nerve compression in the proximal forearm, and pronator teres may develop paresthesias in the same distribution of the carpal tunnel. However, pronator teres syndrome is associated with more proximal forearm pain than wrist and hand pain, and is not associated with pain at night, as seen in carpal tunnel. So lastly, for the MSK section, is the Dupuytren's contracture. This is progressive fibrosis in the palmar fascia leading to contractures as a result of nodules or longitudinal bands, cords, in the palm. Risk factors for this contracture are men over 40, Northern Europeans, alcohol, cirrhosis, diabetes, cigarette smoking. Clinical manifestations are a visible or palpable nodule over the distal palmar crease or proximal phalanx, especially the ring finger and little finger, along the course of the flexor tendons. So there's that palpable nodule, importantly. May have a thickened skin or bands in the palmar fascia. The nodule may be tender. The cords and contractures are usually painless. Fixed flexion deformity at the MCP joint, with limited extension of the MCP or PIP joints. Important. Fixed flexion deformity. So they're stuck basically in flexion, and you'll have a nodule to palpate as well. Management: intralesional collagenase and or corticosteroid injections. Physical therapy: high recurrence rate after injections. Surgical correction: fasciotomy or fasciectomy for advanced stages, refractory cases, or impaired function. And that concludes the MSK section of Pance Prep Pearls. Thank you for listening.